but they published in May of 2020 their first article or report in relation to deaths by ethnic group. Is that right?
That's correct. Yes.
And that's a document that you're familiar with.
Yes.
And indeed, we've heard already from Professor Sir Ian Diamond that you have been in contact with him and worked with him at various stages. Is that right?
That's correct. Yes.
In relation to that article and the statistics that were produced, the provisional analysis showed the risk of death involving COVID-19 among some ethnic groups was significantly higher than that within the white ethnicity population.
That's correct.
When taking into account age in that analysis, so this is right at the beginning of the pandemic, what was known as at May of 2020, black males were 4.2 times more likely to die from a COVID-19 related death, and black females 4.3 times more likely than white ethnicity males and females.
That's correct, yes.
At that point, it was also noted, and this will become relevant for later in terms of the progression of the pandemic, significantly higher raised risk of death, but that those risk factors or the extent of the disproportionality dropped once one had taken into account age, but also other socio-demographic characteristics, including self-reported health and disability. And this relied on collation of data, including the 2011 census.
That's correct, yes.
And that reduced then to males and females of black ethnicity being 1.9 times more likely than those of white ethnicity, and Bangladeshi and Pakistani ethnic minority men being 1.8 times more likely to have a COVID-19 related death. So at this point, in terms of the ONS statistics, is it right to say that it was already flagging up issues in relation to comorbidities that existed within ethnic minority populations and geographic issues, but that the disparity could not simply be explained by those?
That's right. So basically, it was 4 times the risk. Once you take into account the deprivation, the previous health, risk by 50%. So 50% was accounted for by those factors.
That was followed thereafter in June, so again dealing with what was known at the outset and as the pandemic progressed, by the first of the Public Health England reports.
That's correct.
That in relation to that PHE report, certainly there were concerns initially that a truncated report had been published. Is that right?
This is from a BMJ article written by Professor Raj Bhopal, because he'd peer-reviewed the article, and he wrote in the BMJ stating that he'd seen a fuller report inform the public that there were bits of the report missing.
And what bits of the report were missing?
From what we understand, it was the recommendations that may have been missing.
Recommendations. Were there also aspects of stakeholder engagement that were missing?
The stakeholder was, I think, from my recollection, is the second
report.
That's right, yes.
That caused a considerable degree of controversy. Is that fair to say?
That's correct, yes, it did, yes.
And that consequently resulted in a fuller report being published.
Yeah.
You analysed that report. Is that right?
That's right, yes. We didn't peer review it. Once it was published, we and many others looked at it and to see the content and the depth of the report.
Indeed. And in relation to that, were issues flagged in relation to structural racism and discrimination?
That's right.
As a link?
That's correct, yes.
And socio-economic circumstance?
That's correct, yes.
Now, given the link between, or potential link between structural racism and discrimination and those poor health outcomes, as noted in that PHE report, are you aware of any other work that looked at those issues?
there's been a number of studies. The issue with structural discrimination is how you measure it. It's very, very difficult to. Qualitative interviews where people are asked about it, you can get a lot of information from. There's a systematic review that's been done about the disproportionate outcomes in people from ethnic minority backgrounds, and that identified, I think, just a few papers that had talked about discrimination. And again, they highlight that evidence we have from the British Medical Association, from the nurses, associations, that there may have been some elements of structural discrimination, for example, getting PPE given to
And we've heard earlier evidence that ethnic minorities are overrepresented within the healthcare workforce.
That's right, about 20% of the healthcare workforce of 1.2 to 1.5 million people within the National Health Service are from ethnic minority backgrounds, yes.
Thank you. Now, in relation to that PHE report, you wrote of some of the limitations, that, as you saw it, of those reports. The first aspect is that, albeit that they were welcome, because they did shine a light, it was nonetheless a missed opportunity to address significant inequalities in ethnic minority communities. How did you see it as a missed opportunity?
Well, first of all, the report is very comprehensive, and it was very laudable, the amount of work they did, speaking to 4,000 individuals, speaking to a number of stakeholders, so it's a vast amount of work that's done. The reason we thought it was a missed opportunity, because they did have, I think, 6 recommendations, is that they didn't have the recommendations, although they'd identified them, of the wider social determinants. So first of all, how to protect these populations, and the wider social determinants of how to ensure that housing is adequate, it's not overcrowded housing, the occupations that people were at higher risk, they weren't protected, the educational elements, communication, how it was to be done, who was going to do it, all of that wasn't there in huge detail, although they'd identified all the drivers. The recommendations of drivers, the detailed recommendations on drivers were missing.
And there were significant gaps in your view, is that right?
That's correct, yes.
Now, picking up in June of 2020, which is of course when the PHE reports, first report was released, you're aware that ethnicity was discussed at one of the SAGE meetings in June. It was SAGE 40th meeting on the 4th of June.
That's correct, yes.
Within that meeting that the evidence suggested a significantly higher likelihood of, firstly, testing positive, secondly, admission to critical care, and thirdly, the prospects of death for ethnic minorities.
That's correct, yes.
And in particular, that related to Black and South Asian groups.
That's correct, yes.
At that point, as you've already identified, the risk factors or the causative links were assessed as being due to a complex interconnected range of factors, including socioeconomic deprivation, involvement in high-risk occupations, geography, household size, and comorbidities. Did that chime with what you were seeing?
That's exactly, and that's exactly what the initial report by ONS and the Public Health England report also shone a light to as well.
Now, as I said at the outset, you went on to become the chair of the SAGE ethnicity subgroup. That was set up on the 5th of August. How did that come about?
So I had an email from Go Science that they wanted to speak to me, and we had a Zoom or a MST meeting, and that's when Sir Patrick Vallance came along with the Go Science team and mentioned to me that they'd seen the signal and they were asking me if I would be willing to chair this subgroup.
You cannot assist us with why that subgroup was not formed earlier, is that right?
I think that people were trying to find the evidence for this, and as you say, we need validation from various data sets. So ONS signal was the first lot, then the PHE data came out. I mean, if you look at the PHE data, we may be talking about data later, but the Public Health England report, they didn't have anything on occupation. They didn't have data on occupation. So we don't know whether that would have reduced the risk. So until then, I think they weren't the data weren't as robust. And following the Public Health report, Public Health England report, I think they decided they needed a chair for the ethnicity subgroup.
And so you took on that role.
That's correct, yes.
And that subcommittee reported directly to SAGE. Respiratory virus, and therefore perhaps those issues weren't considered in the same way they might have been had it been seen as actually what it was. But was it foreseeable that there would be a disproportionate impact on ethnic minorities?
Potentially, I think that looking back on it, potentially we could have thought about it because of the pre-pandemic disparities, and I think they've been discussed previously at the inquiry. Among ethnic minority groups, particularly in terms of deprivation, health, housing, schooling, etc.
Now, moving to the autumn period, briefly, you had some level of involvement with the minister who was placed in charge of considering the issues of ethnicity. That's the Right Honourable Kemi Badenoch, MP. What involvement did you have, firstly, with her?
I think there was the two meetings that I seem to have found. The Cabinet Office contacted me that Right Honourable Kemi Badenoch wanted to speak to me, this was in October and another one in December. The October one was a general discussion of what the SAGE group were doing. I don't have any firm recollection, but it would have been a high-level discussion of what SAGE is looking at. I think the 16th of December one was a teaching session that we did for cross-governmental departments.
And I understand you did two teaching sessions.
That's correct. One was on the drivers of risk, and one was on housing. I think vaccinations and housing.
And Kemi Badenoch's team went on to produce 4 quarterly reports to the Prime Minister between June 2020 and December 2021.
That's correct.
Did you or the ethnicity subgroup contribute to any of those reports?
We were asked to review them, and we had to review them at pace. We did give some comments on them. I was asked by one of the officers to see if I would give a quote to the report, but thinking through the SAGE committee, we felt that was inappropriate because SAGE was an independent research and science body.
So was the view to keep that separate, effectively, the SAGE workings and those individuals, and then government produce reports? Because
they already had advisors who were acknowledging and supporting the report.
And the work that had been done in relation to those quarterly reports had been done by the equalities team, as opposed to the ethnicity subgroup that you chaired?
That's correct, yes.
Thank you. So, by September of 2020, aspects in relation to causative links were known in relation to occupation. housing, instability, socioeconomic status, comorbidities, and the other aspects.
Occupations. Yeah.
Did you and the SAGE ethnicity subgroup have regard to those factors in advising on policy and response?
We had a paper that was quite a comprehensive paper on drivers of the increased risk among ethnic minority groups, yes.
And indeed, perhaps we can take you to that now. Is it INQ 000273842? I'm going to deal with it briefly, if I may, whilst just perhaps prefacing it before it's brought up on the screen. It's a very lengthy report, sets out in detail where you and the ethnicity subgroup see the drivers as being. Perhaps if we could just go to page 110, please. It's Appendix 7. This is the paper. And in relation to that, I'm very sorry, I thought it was at page 110. And if they go to page 114, please. There's a very useful visual aid.
113.
We can roll down.
113.
113, please.
Yes.
To 113. There's a very useful visual aid that sets out the subgroup's workings. It builds on a paper that's been adapted by another academic in relation to these issues. Is that right?
That's correct, yes.
And I'm afraid it's a little difficult to see on the screen because of the size of the fonts. But if I can just take you to what is seen as number 1, effectively what we see is a diagram. At the top it explains shaped by structural racism and other power structures. Is that the context in which this is placed?
That's right, yes. Yeah.
Then what we see is a green box that deals with dimensions of ethnicity. Aligned to that to the left, we see the differential exposure and vulnerability in the drivers. I'm going to come to that in a moment. And then the output to the far left. Is that right?
That's correct, yes.
So taking each one of those briefly in turn, we have pathway 1. It's the second box, white box down from the top. And the first issue in relation to ethnicity, understanding ethnicity, is differential exposure. What are the issues that arise there in relation to certain ethnic minority groups?
So this is what we've just been talking about in terms of the risk of a higher exposure among ethnic minority populations. So this is things like occupations. They are more likely to work in occupations that they're in direct contact. Housing, living in high density housing, so small houses with large number of occupants. Living in multi-generational houses, which is where we state that there's 3 or more generations living together. There's also people who are have a poor health, so they may have other health conditions, as we've talked about, diabetes, cardiovascular disease, etc. So these are all the issues that may put them at higher exposure. So and healthcare workers is obviously another one.
So this is the first aspect, is exposure to the virus.
That's
so there is a potentially disproportionate level of exposure for ethnic minority individuals
that's right.
because of those factors. That then may or may not result, as we see, if we take it across and then go down, may or may not result in COVID infection. And that then goes into driver 2, which is differential susceptibility. And in summary, is it the case that minority ethnic groups may be at greater risk, in your view, of infection because of differences in immune response, nutritional status, and other
conditions, and obesity is another big risk factor for ethnic minority populations as well. Yes.
And we've heard a little bit about obesity already in that respect. We then see that once one has the infection, there is then potentially a differential vulnerability to the disease. Is that right?
That's right, yes. And some of these overlap as well, as you can see. So this could be because they have higher stress levels, they may be living in areas that have poor air quality, etc.
Okay. And then that results then in the differential consequences of the disease, of an infection of COVID-19, is that right?
Yeah, so basically here, if they become ill, they have more disability, there's job losses, poorer health, perpetuating this cycle of worse outcomes for them. Yes.
And just health outcome, what you identify here are issues such as comorbidity and then access to healthcare,
yes.
Quality of healthcare.
Yeah, and access to healthcare may be a driver from the right side of the dimension. This is about language and culture and not identifying the disease, not properly being able to express the disease, not being aware of the disease and the consequences. So all of those on the right-hand side also are drivers across all the pathway. Yeah.
Indeed. And then what we see there is the potential enhanced risk then of mortality, of death, essentially, that flows through that particular driver. And then as we continue down, the differential social consequences in relation to follow-on impacts from that disease.
That's correct, yes.
Thank you. And you do also touch upon within this differential consequences of control measures. I'm not going to go into that with you in any detail today. We'll talk a little bit about communications later. Thank you. But in short, those are the identified pathways by the ethnicity subgroup.
Yeah,
right?
I mean, this is a theoretical framework that we put the pathways through, yes.
Just drilling down very briefly and flagging them up. You've already dealt with occupation. Household circumstance, that became very important, is that right, when it comes to looking at subsequent issues in relation to the second wave?
That's right. So there was a separate paper that we did as an ethnicity subgroup, and here we wanted to validate the data about multi-generational households. And I think we must have heard we have the best data in the world, and we had 5 database studies that all concurred to the same conclusion that multi-generational households, people with 3 or more occupants, was associated with worse infection, worse disease, and worse mortality.
Perhaps if I can just pick up on that then in relation to the first wave and the second wave. In the first wave, all ethnic minority groups were at that elevated risk, particularly acute within black populations, is that right?
That's right, yes.
But that changed when it came to the second wave, where one saw a decrease in relation to mortality deaths for black ethnic minority populations, but a greater disproportionate effect in relation to Bangladeshi and Pakistani South Asian groups. Is that right?
That's correct. So overall, basically it showed that lockdown worked for nearly most of the ethnic groups, including the white group. You saw a reduction in infection and mortality. But there was a higher risk in Bangladeshis and Pakistanis, and we looked at what the drivers were, and this is using the ONS data. And the drivers were likely to be what we already said, the occupations that ethnic minorities are in, the housing density.
I can just pause you just for one moment. When you say occupations, what types of work?
So occupation is the people-facing roles, taxi drivers, restaurants, healthcare workers, etc., and people who were on 0-hour contracts, so they weren't able to get time out, and so potentially they weren't reporting their symptoms.
Did you, and just picking up on the people with 0-hour contracts, is that in terms of financial stability, did you see that as having any role?
That was one of the reasons that we put forward. That would have definitely been one of the reasons, and some of the qualitative interviews have previously shown that as well, yes.
I think one of the recommendations that you made at that point was for the provision of proper statutory pay, effectively.
Absolutely, yes. Yeah.
Sick pay.
And similarly, we made recommendations on housing, that if people are in multi-generational housing, there should be provision made of housing given for isolation if one member of the house was infected.
Thank you. And then just to pick up on one final aspect in relation to the drivers, can I just be clear with you in relation to genetic considerations? Do you consider it likely that genetics play a role?
Well, most of the data shows that there are some what we call SNPs, genetic signals, but there is no conclusive evidence to show that this is driven by genetic. It does seem to be driven mainly by the social determinants. And we've done some additional work subsequently showing that if we take 25% of the most deprived populations out of deprivation, we halve the risk of COVID infections and mortality. If we take 50% of the most deprived population out of deprivation, including at minorities, we near enough eliminate the risk that we've seen. I feel is due to the social determinants.
And just picking up on deprivation and the use of the 2011 census, because of course that informs the ONS statistics.
That's right.
It's your view, is that right, that as a consequence of that, socioeconomic circumstance and deprivation in relation to the role that it plays because of changes since 2011?
Surveys that they would be better placed. We've also seen in the surveys that the proportion of ethnic minorities has increased in England. In terms of whether they're in more deprived areas, I'm not aware of, but it's likely have changed, yes.
And one final aspect, and that relates to biological factors. When you refer to biological factors, what you are referring to are comorbidities such as diabetes. Right.
That's correct. It's diabetes, cardiovascular disease, obesity. There's some possibility of associations with psychological aspects as well.
Indeed, and that's why I just wanted to be very clear about that. That's what you mean by biological. It's not genetic. It's those comorbidities.
That's correct. Yes.
Thank you. Now, if I may pick up then on what that meant for the COVID-19 response. This response, do you consider that it was successful in addressing those disparities, or could other things have been done?
So the 4 quarter reports mention a number of areas that the government addressed the disparities. This is the Race Disparity Unit 4 quarter reports. There are a number of things that could be done. In terms of the detail, again, some of them are lacking. There's data variations of what worked, what didn't work. I mentioned about worked with our community champions within those areas, our community leaders in those areas, the pharmacists, the GPs, that as we did in Leicester, to reduce that risk. Similarly, the test trace isolation program, again, we didn't have any data coming to us to say where are the bottlenecks, which areas are working well, which are not working well. And again, if this data came on a regular basis in real time, the local public health messaging could have been done. In the reports, the mentions about the culturally adapted information that was given out there. Now, giving out a culturally adapted leaflet doesn't mean that's going to have a major effect. You need to do a lot more than that. You need to work with that community. And there are discussions about the community champions programs that were funded. But again, we're not sure how these were funded, which areas were funded. And the key one is the evaluations. Over £40 million was given out. These are the kind of things that we should be evaluating robustly because we have the data. If you put an intervention in Leicester and don't put it in Blackburn, I can tell within a short period of time with the data that we have whether that intervention's worked or not.
Thank you. And so is that one of your primary concerns, is working at what happened effectively with those community champions grants and research projects and that data?
There are soft evaluations that have been done for one of them, but others we're not aware of what the findings are and how we can implement them. For example, we should be implementing them now. COVID is still here. We're seeing an increased risk, but we're not hearing anything about those messages. And when I say regarding the communication and language, Leicester has over 80 languages. London has over 300 languages. What we need to do is the local people will know the best about what their needs are, and it really needs to be localised in terms of the response.
Thank you.
Can I just ask, sorry to interrupt.
Of course, not at all.
Who had the data that you needed?
I'm not sure if the government had the data. If that was one of the asks, I'm sure Sir Ian Diamond would have provided that data, which he's done for a number of things. The ONS have done an absolute stern job in getting data to us quickly.
It's just that you began this passage in relation saying we had one of the best data systems in the world.
That's
so
right.
I assume by that you meant we were collecting the data, but
it wasn't coming to us. That's right.
So it wasn't being shared with you.
That's right.
But you don't know where it was.
No.
Right.
Thank you. I was going to pick up on that myself, so that's helpful. No, not at all. That's helpful. And you've explained about the need for real-time data and that gap and lacuna there. One of the other aspects that you just touched upon, and perhaps we'll go there next, in fact, because you've explained the need already for culturally sensitive and appropriate government communications, is to pick up on communications. You were involved with the Centre for Ethnic Health Research, is that right?
That's correct, yes.
And you made various recommendations and infographics in relation to culturally sensitive and adapted communications. And if I could ask that be called up, please. It's INQ 000223040. If we can go firstly to page 27 and then move to look at 28 and 29. I'll just while it's coming up, the first page, here we are. This is your recommendation as to how to engage and involve ethnic minority communities, is that right?
That's correct. Yes, this is from the Centre for Ethnic Health Research and the South Asian Health Foundation.
And what we see here is at the very top, use of culturally tailored messaging, different languages and formats. Some aspects in relation to vaccine hesitancy and perhaps more generally and with more general application, the use of community and faith centres as part of that response.
That's correct, yes.
But perhaps one of the starkest things here is actually the picture that's in the centre of the page, because of course that reflects different ethnic minorities. Clearly, would that be correct?
That's correct, yes.
Presumably that's the purpose of it. But we also see in advice to government professionals, policymakers and scientists, the use of interpreters, accurate ethnicity coding, you address PPE, all of those sorts of issues. If we go over the page to page 27, what we then see is an infographic that's been designed for ethnic minority communities specifically, is that right?
That's
Building
correct.
on, effectively, the infographic we saw previously.
That's correct, yes.
So again, representative pictorial descriptions in the middle, and then very clear pictures as to what to do. Stay at home and away from others if ill, in the top left-hand corner. Get tested, a picture of somebody with a test, vaccine, speak to your GP, take part in research studies. So what you have is something that is, at the very least, albeit this one's in English, you have the pictorial representations.
That's right. I'm not sure if you got the exhibits, but we had these in 4 or 5 languages as well.
Indeed. I don't have all of those exhibits, I'm afraid, but certainly it's going to pick up on that, and that's how they've been produced.
And the thing about this is not just translation and back translation. A lot of people say we did some translation and back translation. That's not how cultural competency works. We have to sit with that go through the nuances of what this means to them, and it does take time, and that's what we did with all these infographics. For example, the word BMI. You and I will know what BMI is. Ethnic minorities don't know what BMI is. There is no word for BMI in South Asian languages.
And I understand the same. Certainly in our understanding of just picking up on culturally appropriate messaging and communications, that's quite separate to targeting interventions or communications, isn't it?
That's absolutely, yes, it is.
And in relation to targeting, there are concerns that tailored public health messaging aimed at very specific subgroups of the population can result in greater stigmatisation, racialisation, and those sorts of issues. Is that right?
If you pick on one minority ethnic group, and whether it's culturally tailored or not, they will be signalled out as a high risk. And that will marginalise them, that will stigmatise them, that will create distrust in that population. So it's how that's been done. And what we were saying is this message is for everyone. The messaging during pandemic should have gone to everyone at the same time. But then, in a nuanced way, made it appropriate for that population, so they know that everyone's getting this, but we're just getting it so that we can understand it better.
Indeed, that's the distinction essentially, that the messaging in general terms is the same across all populations, but it's then tailored specifically in terms of those communication aids.
That's correct. I mean, we had an example of that in Leicester. We had a bus in an area where we had high vaccination rates, and this bus turned up with a billboard saying about vaccinations. Now, it was totally inappropriate to have a billboard there when we already had high vaccination rates there.
So what was the impact of that?
Well, the local communities felt stigmatized. Why are we, we've worked very hard. The GP said we worked very hard to get the patients vaccinated. But the people who why are the billboards still coming? Because the vaccination rates are already high in that area, because the local community worked really, really hard. They thought enough wasn't possibly being done by that community.
So they didn't see the message and say, but we're ahead of the game here.
Well, different people will take it differently, as you can imagine.
And were similar billboards in other areas of Leicester?
As far as I'm aware, yes.
Thank you. Thank you. Those are all the questions I have on communications. If I can touch very briefly now on additional involvement within the COVID-19 response. You were also involved in Independence Age, is that right?
That's correct, yes.
And your role there was as a primary care researcher. And as you've already explained, you are a GP by professional background. And indeed, you remain, as I understand it, a practising GP and a clinician.
That's correct, yes.
And that was the reason why you were invited to join.
That's my impression, yes.
And in terms of your input into Independence Age, was that based on your role as a clinician?
As a clinician, I think the ethnic minority work that I'd done was also important to them as well.
And what were the distinctions in the type of work that you were doing for Independent Sage as opposed to your role in the Sage subcommittee for ethnicity?
I think Independent Sage was discussing various aspects on a regular basis, and then the main aim was to get it out to the public, while within SAGE, the issues were about looking at the problem, looking at the science, getting the group together to look at the science, and then give robust evidence to the government in terms of the interventions that need to be put in place.
Did you see any disadvantages in the role of independent SAGE?
I didn't see any disadvantages at all. In fact, when I was asked by Sir Patrick Vallance to join the SAGE, I did mention to him that I was part of independent SAGE, and he was. There wasn't any reason for me to stop independent SAGE at that stage. Yeah.
Thank you. And indeed, you carried on in independent SAGE.
That's correct. Yes.
And the reason that you left was because of a lack of time, essentially.
Absolutely. Yes.
And we've already heard a lot about the types of work that you were already engaged in the pandemic response. And the final area in that regard is in relation to long COVID. And you've explained that you were the chair of the National Long COVID Research Working Group, often referred to within documents as just the Research Working Group, for short. That group first met on the 11th of March 2021 and continues to meet, in fact. Is that right?
That's correct, yes.
Yes, of course. I've just been asked, Professor Khunti, can you just keep your voice up, please?
Okay, will do.
Thank you. No, not at all. With regard to that working group, just to place it in context, there are representatives from the 9 major long COVID epidemiological studies in the UK, and indeed we're going to be hearing from 2 of those individuals, and I understand that they're colleagues that are well known to you, Professor Breitling and Dr. Evans, on Friday, and so as a consequence of that, I'm not going to take you through the clinical or those sorts of issues because
Sure.
we'll be hearing from them. But what I do wish to just touch upon you with is why that group was formed. And can you just explain very briefly how that came about?
So I think this was following an email exchange we had, and there is an email in the evidence from Chris Whitty to myself, Professor Ian Diamond and Nish Chaturvedi, about a lot of work that's going on to see if we can coordinate this work together. And so I emailed the epidemiological groups that were funded from NIHR, the UKRI, and ONS obviously was doing the work, and they all agreed to be part of this group.
Indeed, and if I can just, for those that are following, the email is at INQ0000729959. That's the email from Professor Sir Chris Whitty to you and Professor Sir Ian Diamond. Following on from that, you set right?
That's correct, yes.
As you've just explained. Were you under the impression that you reported to the CMO, to Professor Sir Chris Whitty?
He'd asked us to set this group up, so whether it's reporting or he certainly was interested in what was going on, and he wanted to know what was going on a regular basis. So I think we initially said it was reporting, but it was really what we were doing is sharing what we were doing with Professor Chris Whitty on a regular basis. Initially it was 2 weekly, now it's 4 weekly.
Indeed. One of the things that he asked you to consider was to coordinate on a definition, as we can see from this email, case definitions. Why was that? And the reason I asked that question is because there were already definitions from both the World Health Organization, as you know, and indeed NICE, or NICE rather.
Yeah, so the definitions have been very different, and if you look at the data for long COVID, they vary. Some say 4 weeks, some say 8 weeks, some say 12 weeks. So I think in terms of definitions, we did take the NICE definition, and it was just to ensure that everyone was working in a similar manner as far as the definition goes. We weren't going to redefine the definition unless there was any evidence to do that, but our role was not to redefine the definition.
Thank you. Now, just in terms of the working group and the output, the product of it, if I can just call up INQ 00073726, it's an email from you to Chris Whitty. And what you explained there is that you've been having the fortnightly long COVID meetings, been enormously useful and productive. You explained that one of the initiatives that has resulted is a collection of long COVID research papers, similar to the COVID-19 research collection held by UCL, which we may hear some of later in the evidence. And so, but the point of your email was really to ask if he was agreeable to him using his name in relation to that research collection. Is that right?
That's correct, yes.
And he replies shortly thereafter, and we see at the top there, that he says, I think it'd be sensible not to put the CMO bit in, as it might at some point get people asking about clearances from one side, presumably that's the government side, and independence from government on the other side, and thinking that I endorse papers. And how did that chime with what you'd understood? It's from, as I say, an official within DHSC, but working from private secretary to Professor Sir Chris Whitty. And what that does is it flags this in relation to a subsequent aspect in terms of publication and the use of the CMO's name. And what we see here is that there's a description, Nature, the group is planning to publish the attached commentary in Nature. That's a journal, isn't it?
That's right, yes.
And you've asked whether Professor Chris Whitty would be happy to have the below line included. And what we see there is that it essentially says researchers on these studies have formed the National Long COVID Working Group, reporting to the Chief Medical Officer for England to share key findings and promote understanding and so on. Now, in relation to that, that was being flagged, and you can see underneath it says, from my understanding of the group, reporting to is possibly a bit strong, slightly overstates your involvement, and they make a proposed modification.
So reporting would mean that he would have a say in what we do, which he absolutely doesn't. And we inform him, as I said, with the minutes on a 2-weekly or 4-weekly, and he always acknowledges that it's been helpful for him as the CMO.
Did you form any impression that he was seeking to keep the working group effectively at arm's length?
Well, because it's not funded by the CMO, it's funded by NIHR, UKRI, so he wouldn't have a say in any of the workings of the group or the individual studies.
And that perhaps brings me on to the next point, which is, why was the working group not set up as a subgroup of SAGE? Can you assist us with that?
Yes, sure. So if you look at all the evidence that's been provided so far, there was a paper to SAGE, I think led by Nish Chaturvedi in July of 2021, of a number of groups that had looked at long COVID. And the report stated that they were conducting epidemiological studies. The SAGE's response would be, if there is something concrete there that we can help to improve outcomes, that we can do something about, then they would take that forward as a recommendation to the government. Until now, most of the studies are still evaluating. Even Chris Breitling in his report said we're in its infancy of long COVID. So the research is still being done. What we don't know exactly is the exact cause. Still in the
A lack of importance given to long COVID because it's not a formal subgroup of SAGE?
Absolutely not. If there wasn't importance put to it, they wouldn't have discussed it at SAGE, but it has been discussed. And I currently that the evidence
can just pause for a moment. You've answered a number of the areas, and so I'm just going to truncate those. Just dealing very briefly, because as I say, we will be hearing on Friday from Professor Breitling and his colleagues in relation to that, and Dr. Evans. In terms of your understanding, am I right that the incidence was aware and apparent throughout late spring and early September and early summer of 2020?
That's when the reports started coming out, mainly from the patient groups and then from the researchers themselves, yes.
And indeed, in August 2020, guidance was published in the...
That's correct, yes.
Thank you. We will be hearing a little bit more about your short report that the working group produced in due course, so I don't propose to take you through those today. A little bit already, and indeed from Professor Sir Ian Diamond, that the ONS worked with you in relation to statistics. Can you recall when that was?
Statistics in relation to long COVID.
My apologies.
So I think that was in the SAGE minutes of November 2020.
Indeed, it was. I believe it's SAGE 69, if it exists, on the 19th of November.
That's
really
correct.
Just to get a broad understanding.
So I was representing the ethnicity subgroup within the main SAGE meetings, but because I'd done some work in the area of long COVID, I was asked to work with ONS, and that's when they were starting the CIS, the COVID infection survey, and they were going to add the long COVID questions to that. And it was just to work with the team regarding the questions that were going to be asked and how the study was going to be set up.
With regard to your involvement in SAGE and advice provided, were there discussions about advice to be provided to government decision makers and policy makers in relation to long COVID?
Not that I'm aware of, no.
Thank you. In fact, it appears that the first detailed discussion on long COVID doesn't take place until February 2021.
Mm-hmm.
Can you help us with why it may be that it took so long?
I think most of it's because, as I've said, there wasn't any evidence there that one could change anything in terms of long COVID. Long COVID was this new disease. We still don't know much about long COVID, as you'll hear from Chris Breitling. So at this phase, it was mainly the trying to get informed from the studies that are being done, which are still, many of them are still not complete.
You've had the opportunity of reading the report, haven't you? And just in general high-level terms, do you agree with the report of Professors Breitling and Dr. Evans?
Yes, completely agree, yes.
You completely agree, thank you.
Those areas about funding, I think he mentions, which we've discussed at long COVID meetings as well, and we do agree further funding is required, but there are NIHR calls that people can go to continue doing this work if they wanted to extend their work.
I just have three very short points, if I may, and then I'll be handing over my lady. The first relates then to the collection of data in relation to long COVID. Effectively, at the outset of the pandemic, as we've heard, data was not being collected. In terms of that, are there any recommendations that you would make with regard to population level data collation?
I think longer term, we've learned a lot from this pandemic. There's a number of areas that we can look at, but in terms of long COVID, I think we need to start planning for this very early. And the studies like CIS and the REACT, these are what we call now hibernating studies. We're not doing them, but they could easily be set up. If another pandemic came, they could very quickly be set up.
Essentially use as sleeping studies to be activated.
That's
is that
right.
Right? Thank you. And then in terms of coding issues, a further tweet from you, because you appear to use social media in this way, INQ000280199. You tweeted that long COVID is poorly coded in primary care records, but there are other ways, again, in relation to collation of data. What other ways do you see?
So the coding structures came very quickly. I think there were 18 codes that were set up for long COVID within the GP systems. The tweet was in relation to a paper that was published a month before from Open Safely that in the British Journal of General Practice that showed that only 0.04% of practices at population level had a code for long COVID. By that time, we'd had a number of people with long COVID, but only 0.04% was shown on the GP computer systems, and it was variable. 25% of practices did not have a code at all. So it showed that there is an issue with coding of long COVID. The other areas are that if patients are going to long COVID clinics, for example, if they came back to the practice, that's one way of putting long COVID codes in. Otherwise, we have to do them prospectively. I think the diagnosis, because the diagnosis is so difficult of long COVID, unless you're a researcher, we're doing that on a regular basis. In clinical practice, long COVID is a difficult diagnosis for a busy general practitioner. There are training elements already been put in for that, though.
We've heard a little bit about that, and obviously we can surmise, and you've covered the implications for that within your statement in relation to assessing that. Finally, just in relation to ethnicity and sex, it appears that data concerning ethnicity at the moment is less consistent in relation to having a causal link or that enhanced risk of long COVID. Is that right?
Yes, there are. So there are some studies that have shown that ethnic minorities may have long COVID when we look at the large data sets. When we look at prospective studies where people are asked about long COVID, we seem to see less long COVID. But again, I think there may be some nuances here. We've seen ethnic minorities get worse disease. We'd expect them to get more long COVID. But this may be the language that's used. And I don't think there's work that's been done in terms of the language of long COVID with ethnic minorities, and that's an area of work that certainly needs to be done.
So we still have a gap there.
Absolutely.
And can you just assist with women? Because women appear to be disproportionately impacted in terms of the initial outputs from some of these research studies. Do you know why that is?
I don't, sorry.
Not at all. And we'll be hearing, as I say, from Professor Breitling and Dr. Evans in any event in due course. My lady, those are my questions. There have been applications that have been granted by two core participants. The first is
Mr. Thomas.
Hello. Professor, I represent the Federation of Ethnic Minority Healthcare Organisations, FEMHO. I've only got a few questions for you. One of my questions has already been asked, but let me come on to the three questions that I do have. My lady, I'm starting from question 2.
Thank you.
Yeah. The chair asked you earlier a question. She said, who had the data that you needed? And your response was you weren't sure, and you said, I'm not sure if the government had the data, or if one asks, I'm sure Sir Ian Diamond would have provided the data. The data wasn't coming to us. My question is this. What was the source of the data in the period leading up to March, April 2020 that connected certain underlying clinical conditions with increased vulnerability to COVID-19?
Okay, so in terms of the data, there were a number of data points that were available to researchers, and obviously they were available to the Office of National Statistics.
Yeah.
In terms of the government, I'm not sure what data were available to them,
Okay.
unless they commissioned the other groups to do the work.
Yeah. But you're clear in your analysis, or let me ask you in a non-leading way, did the analysis of that data that you did have, that suggested a heightened vulnerability to COVID-19 based on race and ethnicity?
Absolutely, yes. And as I mentioned before, it's the ONS data and the Public Health England data also suggested that. And then subsequently, a number of other independent researchers have also identified that risk as well.
Okay, thank you. Let me move on to my next question. If there was a growing expert view in between March, April 2020, that there was indeed a heightened risk to COVID based on race and ethnicity, can you say who the main voices who were making this call, who were, this is a potential problem? Who were the main voices?
So as I said, the first signal that we mentioned earlier was that I was the first one to point that risk out. And as I said, this it was in a cautionary way that we're seeing more people from ethnic minority backgrounds being admitted to hospital, and we'd not heard of this. And then after that, I think the first lot of data we were relying on was the ICNAC data, which is the intensive care unit data that's collected nationally from a number of centres. And we were tweeting this on a regular basis, saying there is still this risk. And then more patients were admitted and saying disproportionately ethnic minorities are more represented in intensive care unit database. So we were the first ones to make all these signals available to people. And then I think that's when ONS started looking at the data.
And can I just follow on from that, if I may? So you were signalling this. Did you consider the level of any such risk to be actionable? You wanted it acted upon?
Before you act on anything, we need a definite confirmation that there is a causal risk there. And we hadn't identified. We knew that there were more patients admitted to the hospital. And I'm talking here of May, June time. And that's when ONS did their first lot of analysis showing and confirming this risk.
Let me move on to my last area. Are you aware of any targeted interventions that was formulated to address the probability of heightened risk COVID based on race and ethnicity? I'll repeat the question if you want me to.
Yeah.
Right. Are you aware of any targeted intervention that was formulated to address the probability of heightened risk to COVID-19 based on race and ethnicity?
So if you look at the 4 quarterly report from the Race Disparity Unit, you do see that there were targeted interventions throughout those 4 reports. And they were at various levels, including the communications that we've talked about, the vaccinations, and more data-driven work that could be done. In terms of my answers I gave earlier, the targeted interventions were, we felt it wasn't coordinated as such. They weren't, the funded individuals, there was about 60 health authorities that were given these funding. They were left to themselves to decide what to do with that rather than having a coordinated effort or even having coordinated pilots to say, let's intervene here in this area, intervene this way in this area to reduce the risk and to identify what are the best interventions that will lead to better outcomes for people from ethnic minority backgrounds.
Yeah, I finished, but just on that, do you think things were being done timely?
The first quarterly report was in October, and that's when they started discussing this. I think the first lot of funding for community champions was given in January 2021. Sorry, January 2021, yes. 23.7.5 million pounds was given for community champions over, I think, 60 authorities. And we think that this could have been done earlier, yes.
It could have been done earlier. My lady, that's all I asked. Thank you.
Thank you, Mr. Thomas. Mr. Medser.
Thank you, my lady.
You're looking that way now, Professor.
Two topics, please, Professor Khunti. First of all, I'm going to cite, I'm not going to go to the INQ number, but it's INQ 000280061, which is part of Sir Patrick Valance's diaries. At page 205, Professor Khunti, he recorded an entry on the 6th of October 2020 listing the reasons why the Great Barrington proposal, namely herd immunity and let it rip, as you'll be aware, is wrong. Number 4 on that list was long COVID. First question, do you agree with Patrick Valance's view that long COVID was one of the reasons why letting the virus spread unchecked was wrong?
Absolutely. I agree with that. As I mentioned earlier, at the moment, the way to reduce the risk of long COVID is through reducing the risk of people getting COVID. And this is through, as we said, all the NPIs. And now we have the vaccines that can drive the risk. Vaccines drive the risk, reduces the risk, and there's good evidence now that if people are vaccinated, they're less likely to get long COVID. If they have long COVID and they're vaccinated, there's also data to suggest that they get less long COVID.
Thank you. Since you've said yes, can you answer this subsidiary question? Should long COVID be one of the factors to take into account in assessing the need for non-pharmaceutical interventions to limit transmission?
Yes, absolutely. As I've said, that's one of the ways of reducing the risk of getting COVID in the first place. And we also know that if you have had COVID and you have long COVID and you have COVID again, your risks are worse. So definitely, yes.
Thank you. And would SAGE be responsible for informing government decision makers about the nature of risk of long COVID, as with other factors on Patrick Valance's list, such as how long immunity lasts?
I think that was already in many of the SAGE papers. The SPI-M modelling had looked at how long the immunity lasts after an infection or vaccinations, and these were all taken into account.
Of page 13 of your report, you said by August 2020, understanding was sufficient for guidance on management of post-acute COVID, as the longer-term effects of COVID-19 were termed, to be published in the British Medical Journal. Is it right that SAGE did not provide advice on long COVID to government decision makers by October 2020, when Sir Patrick Vallance made this note in his diary?
As I mentioned earlier on, there weren't any interventions for people with long COVID, and indeed, you'll hear on Friday we don't have any interventions at the moment. We're really at its infancy in terms of knowing much about long COVID. So at that stage, we did not have any interventions to put into place to help people with long COVID, except to reduce the risk of long COVID with the interventions I mentioned, the NPIs and the vaccination programs.
All right. Well, that ties in well to my second topic that I want to go on to, on recommendations. The long COVID group, the two questions I want to ask you about that in relation to something you've said, I think, both in evidence and paragraph 3.8 of your witness statement. Can we, you of course sat on SAGE, can we look at the minutes of SAGE 94 on the 22nd of July 2021, which is INQ 000092856? Could we go to, please, page 4, paragraph 27? I want to ask you about the fourth line, which starts, for those children who do suffer long illness.
You need to be near the microphone. Sorry.
Oh, I'm sorry. Yes. It's on my screen. It's on my screen, thank you. For those children who do suffer long illness duration, there may be a need for guidance to parents, carers and schools on how to support them. Would you agree that this appears to be a recommendation from SAGE?
That's what it seems like, yes.
Thank you. And do you know if that guidance was prepared?
I'm not aware of that, sorry.
So you're not able to say if it wasn't, why it wasn't?
As I said, I was on the SAGE as a chair of the ethnicity subgroup. I did give comments on long COVID, particularly for the CIS survey. Children's long COVID is not my area of expertise.
So be it. And the last INQ I'd like to take you to 000249. Number 39. That's titled, In the Wake of the Pandemic, Preparing for Long COVID. Can we look at, first of all, the first page and just confirm that you're a co-author?
That's right, yes.
Thank you. Page 4, can we go to, please, which is a correction from the 22nd of March 2021. Can we take that to indicate that the report was published by then, March 2021?
This is the first time I'm seeing this, so if this is there, yes, I do agree.
So you do agree that we can indicate the report must have been published by then, March 2021?
Yes.
Thank you. And the last thing I want to ask you, page 23, please. We can see there a number of recommendations for policymakers. Do you have that, Professor Khunti?
Yes.
Yes. Do you agree that these recommendations could have been put before SAGE?
I'm just reading those.
Yeah, of course.
Yeah, so these are our recommendations stating that we should be implementing patient registers, we should be giving guidelines on multidisciplinary services, but we didn't have any evidence for this at all. These were all consensus recommendations that we gave as part of this document. SAGE was looking at the acute complications and giving advice of trying to reduce the risk associated with this acute effects of the pandemic.
Yes.
In terms of this, there are other areas looking at this. There are already clinics that have been set up to deal with this. These were all actioned by the government in terms of having clinics for people with long COVID. They I think predate some of the discussions on SAGE.
Yes, but we can see the implications for policy makes reference to...
Microphone, Mr. Petzer. Sorry, it's because it's not appearing on your screen.
Oh, I'm very sorry. I'm bending down.
Sorry.
I'll bring it down with me. Although long COVID is not yet fully understood, health policymakers should be preparing to address it.
Yes, so this is to the policymakers in terms of the government policymakers. And we know that they did set up the long COVID clinics because of that.
Yes, the last question I asked, therefore, is SAGE, therefore, could have made similar recommendations on the basis of information available at that time, which is early 2021. Do you agree?
They could have done, but as I said, this wasn't a question that was put towards SAGE to look at this evidence, because there wasn't any evidence. Even the long COVID clinics were set up to help people with COVID, but there wasn't any evidence as such for that.
No, just recommendations?
Yes.
Yes. Thank you.
Thank you, Mr.
Thank
Mason.
you.
Thank you, my lady. That concludes the evidence, unless your ladyship has any questions.
No, I have no more questions. Thank you so much, Professor, for all the work you've done generally and for all your help with this inquiry. We're very grateful.
Thank you very much.
Thank you, my lady. Let me just hand over to Mr. Keith. King's Counsel.
My lady, just before you do that, the next witness is Professor Tom Hale.
I do solemnly,
I do solemnly,
sincerely and truly
sincerely, the truth
the whole but the truth.
and nothing but the truth.
Good morning.
Good morning.
Could you commence, please, by giving the inquiry your full name?
My name is Professor Thomas Hale.
Professor, thank you very much for attending today and for the provision of your expert report prepared for this module, which relates to the Oxford COVID-19 Government Response Tracker, for which you are responsible in part, although you lead the team that has provided and provides that tracker. You've prepared this report for us. It's INQ 257925, and I believe on the last page, perhaps not the last page, which is page 105, but earlier in that report you've appended the usual declaration concerning, in fact, it's on the second page. You set out the usual understanding of your duty to provide independent evidence, and you confirm that you've made clear those matters which are within your knowledge, and those which are not, and those which are true, and those which are not. Now, you are a professor, you are the Professor of Global Public Policy at the Blavatnik School of Government. Is that in the University of Oxford?
That is correct.
And in essence, are you a specialist in the area or the issue of how political institutions evolve, adapt to face the challenges, whatever they may be, that they face globally and in the context of those? Right.
That's correct. I focus especially on trans-border threats, such as pandemics, where we need to look at different government responses, compare them, and understand how they interact.
Professor, whilst you give evidence, please try to keep your answers as slow as you can humanly make them. It makes it much easier for our stenographer. And do you hold a PhD in politics from Princeton, a master's degree in global politics from the LSE, an AB in public policy from Princeton School of Public and International Affairs?
I do.
And have you written for many years on these areas?
I do.
Thank you very much. The report does does it fulfill this main aim, which was to research and review the many thousands of articles and pieces of learning which concern themselves with the impact of the various governmental measures which were applied by governments across the world in response to the pandemic, and based very largely on the information collated by your tracker team.
That's correct. Our project was providing an evidence base for many, many hundreds, indeed thousands of studies that took place looking at what governments were doing in response to the pandemic and what the effects of their policies may or may not be on different outcomes of interest, such as the health of their populations or their economies.
Your tracker, the project which I think you launched in March 2020, obviously looked around the world at all the various responses that the governments across the world put into place. Was it one of a number of trackers? Are you the preeminent tracker of this information, or were there a large number of other bodies also scouring the position around the world to see how governments were responding?
It was the largest of these efforts. There were several of them, which we've listed in the appendix, close collaborators and colleagues, each often providing a different set of. But our project became a focal point for many users of the data because it had huge breadth, covering 185 different countries around.
Their planning processes.
That's correct. So our data were made available instantly by many governments, researchers, media organizations to create a record of who is doing what and how does it compare to, for example, a government's own plans or actions. And that was indeed the idea, to facilitate learning.
And in the United Kingdom, did the two academic leads of the Tracker project, yourself and Dr. Petherick, assist the United Kingdom government by way of taking part in or joining the International Comparators Joint Unit Expert Advisory Group, which provided timely and vital information to the UK government on what the impacts appeared to be of the various different types of measures applied by governments across the world.
That is correct. Dr. Petherick and I had the privilege of serving on this committee beginning from spring of 2020 when it was created, and then through its various forms until around the middle of 2021 when it ceased its work.
Just focusing for a moment on the methodology and how the tracker, how the information tracked in the project was assembled. You've mentioned the very large number of volunteers across the world. Did those volunteers have or were they recruited locally so that they would have the facility, the ability to be able to deploy local knowledge in each country or each jurisdiction or sub-region when being deployed?
That's exactly the strategy that was used. So it's quite important for any kind of comparative exercise to navigate between two fundamental desiderata. One is a comparable system where you can say A is like A, B is like B, which necessarily requires a little bit of abstraction, but also, on the other side, the ability to have real contextual information to understand exactly what a given policy might mean in a particular context, to use the local language to understand that context, understand the meaning of a policy, and to combine those two. And so using a team of volunteers, and I would like to really offer, again, our huge thanks for the way these volunteers gave their time during the pandemic to create this global public good, using that combination of expertise in the local context with a comparable methodology is what allowed the data to emerge.
And do we presume that the data, the information about how the various governmental measures were coming into existence and being deployed and what their impacts were, was assembled by viewing official government websites across the world, official news reports, and any publicly available information about what those measures consisted of?
That's correct. So the volunteers were tasked with looking at, say, an official government website. Measures and restrictions might be posted, or, for example, where that didn't exist, and there are certainly many governments around the world where communication around COVID-19 measures were less consistent and clear than in other parts, where the suitable information was sourced from government websites, maybe a slightly less official kind of document, but a posting on a government website or similar information. And importantly, the project has recorded these original sources as permanent digital records, and so the entire historical archive for each of our data points is there for consideration.
And is that an important feature for the purposes of quality assurance, so that your analysis and your thinking is open to review?
Exactly.
Now, the inquiry has heard a great deal of evidence about non-pharmaceutical interventions and plainly aware of what they are. In terms of the sorts of measures that you tracked, in very broad terms, were those measures what we would call non-pharmaceutical interventions, but also including the impact of vaccine-related measures? So they were broadly the same, but they included the whole field of vaccination.
That's correct. So the project began in the spring of 2020 when the most prominent responses governments were taking to the pandemic were in the form of NPIs, often restrictions on movement or travel or requirements to stay at home. However, as the pandemic evolved, so too did responses to it. And so our project had the imperative of adapting and adding new categories of response as our toolkit against this disease expanded. And that most significantly took the form of measuring the different policies that governments put in place to encourage vaccination, sometimes to require vaccination, and also how some of the restrictions that have been used in the pre-vaccine period, such as travel restrictions, might vary, for example, allowing more freedoms for vaccinated individuals than others. So those complexities were important.
And do we have on page 47 of your report the full list of the Oxford COVID-19 Government Response Tracker indicators, that is to say, the measures or the policies that were tracked? And we can just see that they can be conveniently grouped into containment and closure, economic responses, health systems, and over the page, vaccine policies and miscellaneous.
Correct. And richer descriptions are available on the link provided on page 47.
it's important, isn't it, to identify the limitations on the work that your project was able to carry out. You tracked the measures and you tracked the impact of the measures. But what the project couldn't do was ever identify, for obvious reasons, the counterfactual position. What would have been the impact if these measures had not been applied in the various jurisdictions? Is that correct?
Correct.
And is that because, in very general terms, firstly, this is an observational study. You observed what was happening. It's not a controlled study of what the impact might be in theory of an intervention. Mm-hmm. And secondly, many of these measures and interventions were being applied simultaneously. And therefore, it's impossible to say what the precise impact may have been or was from any individual particular intervention. Is that correct?
Indeed. And so with these differential impacts you might find across different NPIs, it's exceedingly difficult to say in this particular instance, say 5% was done by this one, 10% by another. Instead, the knowledge we're able to glean from the literature is to identify the tendencies that, on average, different kinds of interventions, either individually or in combination, may have.
And of course, if you look at page 47, you can see that the measures are self-defined in very broad terms. School closures or workplace closing, income. Doesn't it, how different governments across the world responded in general terms and what the broad consequences were of those particular governmental decisions. If we look at page 8, by way of a demonstration of a very user-friendly diagram, this, for example, provides a chart by colour of school closures during the COVID-19 pandemic as at the 24th of October 2020, and it shows those countries in which no measures in relation to school closures were imposed, those in which they were recommended, those in which closures were required but only at some levels, and then those countries in which at all levels of school, so all ages, schools were closed.
Correct.
And you can see the broad thrust of it. All right. Turning to the summary of your research of, as I've said, the scientific literature reporting on the information collated by your project and by your tracker, page 11 of your report. Are there a number of general findings that you draw from your review of these thousands of studies reporting on the data which you collated? So in essence, what everybody did. Firstly, speed matters, and we're going to come and look at these in turn. Secondly, strength matters. Those two observations, I think, are self-evident, that their meaning is clear. Third, effective use of test, trace and isolate measures limits both health impacts and the need for restrictive policies. By restrictive policies, do you mean more stringent policies?
Correct.
Stringent measures. Fourthly, economic support bolsters compliance. By that, do you mean the provision of economic support by government, for example, by way of support for those who are self-isolating, tends to improve the ability or the degree to which a population will comply with a particular measure?
Yes.
Fifthly, prolonged restrictions can have costs. What sort of costs, in very broad terms, did you have in mind by that phrase?
There are many potential costs. The ones we focused on because they were a source of great interest in the literature were around mental health impacts, around domestic violence, around learning outcomes for children, and of course for the economy. Of course, there are many others as well to consider.
So now, dealing with each of those broad findings in turn, firstly, speed matters. It may be thought to be self-evident, but what is the broad consequence of a timely, that is to say, a rapid adoption of a non-pharmaceutical intervention? That is to say, the imposition of a social restriction, or a distancing method, or a mask-wearing measure, or a full stay-at-home mandatory order.
So the long experience of managing infectious disease of all kinds shows very clearly that because such diseases tend to spread in a nonlinear and, in the case of COVID-19, rapid fashion, early interventions, when the prevalence is low, are critical to restrain further spread. Once spread has reached a certain scale, and therefore because more spread means in exponential logic more and more spread at a certain speed, it's much harder for any policy to have the same effect it would have had at a lower level of spread. Therefore, speed matters. And for example, one of the studies we looked at showed that a single day of delaying a mass gathering ban, so something like concerts or sporting events, a single day of delay had an impact of perhaps a 7% increase in the cumulative death toll during that wave. So one day, 7% increase, quite a significant importance for speed.
Does your report refer to a number of studies that show, by reference to measures taken during the first 5 days, and also some other studies which show the effects of the implementation of NPIs in general terms during the first 10 to 14 days can have a very significant impact, and did have a very significant impact, upon the transmission of the virus?
Correct. Most of the studies show, and when you might notice the impact of that on the number of cases, which is tied to the time it takes the COVID-19 disease to incubate and spread.
I've described it perhaps a little cheekily as self-evident. It is obvious, though, isn't it, that if you apply a measure, a restriction, because it takes the effect of some sort of restriction, it is bound to have a beneficial impact in terms of limiting the transmission of the virus. But on account of the way in which a viral outbreak or a viral disease will spread, what is the particular significance? What is the particular need for acting fast?
It's precisely to spread that you are inevitably going to have some degree of non-compliance leading to further spread. It's too late for those measures to have the kind of clamp down effect they would have had if it were just a few people. So it's a simple kind of mathematical logic of exponential growth that once you are have passed the point of a certain threshold of spread, it's not going to be feasible to bring that down without a very prolonged and intense level of
reviews, the literature reviews of the tracker and the data that it collated, reach any conclusions in relation to individual NPIs beyond that of the one concerning the banning of mass gathering, to which you've closures? Was there a significant link between the closing of schools and a reduction in the transmission of the virus thereafter?
Yes, so as was mentioned, the exact impact of any single measure in a given instance is always going to be difficult to say because they tend to come in packages. But on balance, the literature shows, as you would expect, policies that are more effective at preventing people from meeting each other are going to be the ones that have the greatest impact on cases, hospitalizations, and eventually deaths. And so stay-at-home measures were obviously one of the we observe one of the strongest overall tendencies to do, but school closures, workplace closures also seem to have this effect.
What about mask wearing?
Mask wearing is indeed one of the factors that has been shown. I think I note the Royal Society's report on this fact showing quite a clear balance of evidence that the right kind of mask wearing in particular has reduced transmission.
And when you say the right type of mask, do you mean medical masks, respirators, as opposed to cloth masks?
That does seem to be where the evidence shows, yes.
Now, you've used the word stringent. In the context of border measures, for example, is there a link between the efficacy, the effect of a particular measure or border measure, and the ruthless degree or the stringency by which such a measure has to be applied?
For border measures, it's important to think slightly more broadly about the role they might play alongside others. So oftentimes, restrictions on international travel were geared not at clamping down on local spread, but, for example, at preventing new entrants into a population, for example, of a new variant. And so I might suggest that they should be assessed in a slightly different way. But yes, on average, we see a tendency for stronger restrictions on travel to be associated with reductions in the spread of the disease.
And is that fairly obvious? Because with border measures, with restrictions on travel, there is a range of measures which could be applied, from screening for symptoms of the virus, whether you've got a temperature, whether or not you're showing signs of fever, all the way across to a full-blown closure of your border.
Correct.
And if you apply a border measure which is or a screening, it is much more likely to allow the virus to continue to enter any particular country, because the nature of that sort of measure is it's extremely hard to police and to enforce and to prevent complete.
Correct. It was really the most stringent measures, for example, closures or required long periods of quarantine, say in hotels, that show this particularly high effect on transmission.
I've already asked you about the generic difficulties of trying to apply a counterfactual position and of trying to drill down into the impact of specific measures. Is it for those reasons that you can't express a view, for example, as to what the specific impact might have been in the United Kingdom of banning of the Six Nations matches which were held in February and March, a football match between Atletico Madrid and Liverpool and so on, and a racing festival at Cheltenham? Does the data and the literature provide you with any answer as to what might have been the impact had those large mass gatherings not taken place?
A study could be done, a modeling study, which would have tried to use mathematics and statistics to create a counterfactual for comparison. But no, we observational way and say, had this been done earlier, definitely this would be the impact. Rather, what we can say is, let's look at all of the countries in the world, see which ones impose these kinds of mass gathering bans, what the impact that was on their disease situations, and then try to interpolate that to the UK. That's the level of evidence that we can provide.
Turning to the second topic, strength matters. Plainly, some measures are more stringent, more ruthless than others. Stay-at-home orders because by virtue of their mandatory nature, are amongst the most strong policy interventions, are they not?
Correct.
And does the data and the review show, not surprisingly, unsurprisingly, that stay-at-home orders had the greatest impact in terms of the policy impact? They had the greatest consequence.
To the extent we can distinguish individual policies, as we've discussed, yes, they do seem to have a very large impact.
Similarly, did the closing of schools and the limiting of mass gatherings also have, as these things go, more effective impact than other less stringent measures?
So some of it would depend on the level of closure. So some mass gatherings, for example, were not completely banned, but were allowed to occur with, say, a 2-meter rule or other kinds of mitigating factors. So we would say a more stringent measure is one at the top of our scale, not so much about the kind of intervention, but rather the degree of stringency through which it was applied.
And perhaps again, self-evidently, the benefit of a more stringent measure was, it would seem, not just a reduction in transmission, but also a better outcome in terms of health and death rates.
Correct.
Did that general proposition apply throughout the pandemic? So in the latter stages of the pandemic across the world, do stringent measures have the same general impact as they did in the earlier stages of the pandemic? And if not, why not?
So we must recognize that the bulk of the evidence in the available scientific literature is based on earlier phases of the pandemic. That's when most of these studies were done, because even though it's now especially self-evident, perhaps to us now, that these kinds of measures did reduce transmission and therefore cases and therefore hospitalizations and therefore deaths, that evidence base did not exist in the same kind of robust way for this particular disease when it had recently emerged. So there's a huge flurry of studies in that first period. As the pandemic progressed, new research questions around, say, vaccination drew attention, and so there was a wider range of topics that needed to be considered. But overall, the studies that were conducted on NPIs across the period of the pandemic do show consistent results. As the pandemic progressed, however, one of the most important things to control for, well, two of the most important things to control for were how vaccinated a population was, how vulnerable it was, how exposed it had been, and in the same vein, how in a more vaccinated population or one that had been exposed to higher levels of infection before, we'll see less of an effect because there's not as much vulnerability. And also, with a more transmissible version of the virus, it will be important, we'll see a less significant effect because more would be needed to achieve less.
So, if I may not do, hoping I don't do a terrible injustice to your learning, trying to summarize it, later during the pandemic, when populations by and large had become more vaccinated, such governmental measures as were put into place at that time would be bound to have less impact and less effect because the populations had by then already become vaccinated. And therefore there was firstly less need for stringent measures, and secondly, by comparison to the beneficial impact of vaccination, whatever stringent measure you might otherwise put into place would have less impact. And secondly, as variants came through with different transmissibility features, for example, a particular variant might have an impact on young persons and children, the closing of schools at that point would have proportionally, therefore, a greater impact.
If that were the case, that would indeed line up in that way. So the overall relationship remains the same. more stringency, more quick speed, fewer cases, fewer deaths, but the size of that effect will go down as the population gains more protection through immunity, and the size of that impact will go down as the transmissibility of the disease increases.
Test, trace and isolate measures were applied by a number of governments. It's common ground and not open now, I think, to serious debate that the United Kingdom was not a country that was able to deploy significant test, trace and isolate measures in the early days of the pandemic. Does your data show that test, trace and isolate measures were, generally speaking, highly effective?
Our review of the literature does show this to be the case, indeed. The evidence base, we must say, though, is harder here because it's very difficult to find comparable information across countries on, for example, the percentage of contacts traced each time, or the time it takes to trace those contacts. Even here in the UK, we don't have necessarily consistent information about those two key variables over the whole course of the pandemic. And so here's a slight difference in the quality of the evidence the world has available, but the studies that have been done nonetheless very clearly show that effective test, trace, isolate, and support measures were very helpful.
Contrary to what I suggested to you earlier, which is that it's generally not possible to demonstrate the counterfactual position, have there in this particular field, the field of test, trace and isolate, nevertheless been some studies which did attempt to predict or to show what the position would have been in the United Kingdom had there been more comprehensive levels of testing and contact tracing?
That's correct. So I would direct you to page 15. We've summarized a study by Panaskova Griffiths et al. 2020, which was, as I said before, a modeling study, so using hypothetical parameters to estimate the effect of a counterfactual. And in that case, they did show that TTI strategies could have been successful, in particular on the second wave of COVID-19 in the UK, if they had been more effective at capturing a wider range of contacts more quickly.
Turning to economic support and the bolstering of compliance, were there a number of studies which showed in general terms that when stronger, so more extensive, more generous economic support policies were adopted, compliance with whatever social measure, for example, self-isolation, that was in place, was better?
Correct. So there are two categories of studies that are particularly relevant here. First, a number that show that existing levels of economic deprivation or short-term economic shocks reduce compliance. And secondly, and relatedly, when there's economic support that's provided, either through government programs, such as the furlough scheme here in the UK, or, as was the case in many countries, through social organizations, for example, in India, an extensive social provision of food to vulnerable households. This was very helpful in ensuring greater compliance with NPIs.
The costs of prolonged restrictions is your next theme. Again, self-evidently, perhaps, the evidence which you looked at strongly suggests that strict and prolonged non-pharmaceutical interventions will have negative impact on mental health, educational prospects, particularly deleterious effects on older adults, and also the increased prevalence in domestic violence.
Correct.
And were there a number of studies which showed that in relation to that latter issue, that of domestic violence, there were substantial increases in domestic violence as a result of the prolonged use of some NPIs. And that was in countries in Europe and in America, across the world.
Indeed, and it's striking to see such consistency in the findings across very different contexts, indeed in countries where the previous levels of domestic violence were also quite different, all showed a similar increase.
Again, we've heard evidence on this from a number of sources. The application of more stringent non-pharmaceutical interventions also had disproportionate impact on various sectors of the populations in each of the countries, on ethnic minorities, members of ethnic minorities, ethnic groups, women, the elderly, those living alone, and those suffering from comorbidity, economically disadvantaged.
That's correct. And surely it's one of the cruelest injustices of this pandemic that often similar people, similar groups of people who are both vulnerable to COVID were also vulnerable to the effects of actions against COVID.
Some countries have, of course, been praised for the stringency and the rapidity, the speed of their non-pharmaceutical interventions, South Korea being one of them. But even in such countries, did those non-pharmaceutical interventions strike disproportionately hard upon some sectors of the population?
They certainly did, and the elderly population in South Korea, one study showed, was particularly negatively affected by the policies the government put in place. And I'd add that these differential impacts were often exploited by the virus to affect the larger population. So, for example, in Singapore, a country which is particularly effective in managing the disease overall, one large, relatively uncontrolled outbreak occurred first in a population of migrant workers who were one of the more marginalized groups in society. And so there, the differential impacts were not just an injustice, but also a detriment to the country's overall response.
Turning to page 19 of your report, you then turn to focus upon the United Government's own responses, but in a comparative perspective, by which do you mean that you've looked at the NPIs which were applied in the United Kingdom and you've compared them in terms of the speed and stringency with which they were imposed by the government here against other countries and in relation to the particular nature of those NPIs?
Correct.
Now, at page 21, do you produce a figure, you call it figure 3A, which shows, in respect of England, Scotland, Wales and Northern Ireland, and by the division of particular NPIs, school closures, workplace closures, cancellation of public events and so on and so forth, how many days elapsed between the first confirmed case of COVID in each of those countries and the point at which that particular NPI was imposed?
Correct.
And in general terms, do you conclude, or does the literature show, that for the majority of these NPIs, England, Scotland, Wales and Northern Ireland delayed, or there was a greater elapse of time before the imposition of these NPIs than really the majority of all other countries?
That's correct. I would also draw your attention to the following figure, 3B, which looks at time.
We were going to get there.
Wonderful.
Well, let me ask you this, Professor. The danger in relying too much upon a chart that shows the delay between the first confirmed case of the virus and the imposition of NPIs is that the first confirmed case has a degree of variability as to when it might be And that may depend on a lot of different reasons. And it may also not be a fair reflection of the extent to which the virus has already spread in a country. So did you, on page 23, compare the position of what delays there had been before the NPIs were applied after the 100th confirmed case in each of the countries?
Correct.
And in general terms, what did that chart show about the extent of the elapse of time, or perhaps more pejoratively, delay?
It shows very clearly, figure 3b, that in relation to the spread of the virus, restrictive measures across the United Kingdom came into place much more slowly than they were put into place in other groups of comparator countries. Different regions, similar countries with similar political systems, those with similar populations or age profiles, etc. And this was particularly true. It was really not the only real place where the United Kingdom's restrictions were broadly comparable were for the two categories, panels E and H, on protection for the elderly and stay-at-home requirements. But on every other MPI we looked at, there's a considerable delay in the UK measures compared to other groups of countries.
And are there 2 points that must be made, 2 additional points that must be made in relation to the chart at 3b? Firstly, it might be thought that England had delayed to a greater extent than Scotland, Wales and Northern Ireland because, for example, in relation to school closures, workplace closures and cancellation of public events, the bar chart is longer. But is that because at the point at which the United Kingdom applied those measures, which it did simultaneously in many places, on many occasions for England, Scotland, Wales and Northern Ireland, by that point in time, the virus had been prevalent in England for longer? That's
correct. So if we were looking at this in normal calendar time, the different parts of the United Kingdom would look much more similar. If we were looking at this in calendar time, the United Kingdom as a whole would look sort of in the middle of the pack relative to most other countries. But of course, the virus doesn't think about calendar time. It thinks about its own spread. And so this chart is showing us, if you will, a virus time perspective. And for decision making, that's, of course, the key metric.
And the second most important point, perhaps, is that the stay-at-home requirement was imposed in the United Kingdom, the mandatory lockdown, of course, simultaneously or very close in time to the cancellation of public events, workplace closures, school closures, and the closing of public transport, because that was the effect of the lockdown. And that is why there is very little by way of a delay in relation to the stay-at-home requirement in the middle of that page.
It's because, yes, the stay-at-home measure came into place relative on March 23rd, quite close to the 100th case, which was, I think it was a few weeks before that. But other kinds of policies have been put into place in softer forms before that. So it wasn't 100%, you must not go to school, but there were different kinds of suggestions that were being made, recommendations, etc. So some of that's captured here as well.
I'm afraid I'm still struggling with the virus time and real time concept. Could you just run it past me again, Professor, please?
Of course, my lady. So the bottom axis here, the x-axis along the bottom, which is a very small number, I apologize. You'll see it shows 0 on the left hand, then goes 5, 10, 15, 20. So those are the number of days since the 100th case. So for England, that will be, this clock will start, I'm sorry I don't have the exact date in my mind, but it'll have started before, because England had 100 cases, long before Scotland did, long before Wales did, and before Northern Ireland did. So for each of these jurisdictions, and as well as all the comparators, we're measuring when they put in place a measure based on how far it was from the 100th case, not when what the date on the calendar was.
Thank you.
Or putting it another way, at the point at which the particular measure was imposed for the United Kingdom, the virus had already spread further in England.
Correct.
And more time had passed since the first or the 100th case.
Correct.
Can we then turn to a different topic, which is on page 24, the comparison between the timing and intensity of UK responses to other countries. On page 25, to go forward one page, you produce table 4, which is entitled, we can see from the left-hand side of the page, Policy Strength. Over time, that is to say the whole period of the pandemic, have you looked at, in these charts, the stringency, the general level of severity of the measures applied by each country, and compared them over time with a very large number of other countries across the world?
Correct.
So if we look at school closures in the top left, the red line, which I think we can see more clearly than other lines, is the United Kingdom, is it not?
That's correct.
And so we can see that in relation to school closures, in the early days, there was a fairly high level of stringency. The United Kingdom was more severe, more strict in terms of the school closures, meaning any possibility of what was being done in relation to schools. But then the red line comes right down to a very low level of stringency and then goes back up. Similarly, workplace closures on the right-hand side, we can see that in the early days, workplace closure was prevalent, of course, in the United Kingdom because of the lockdown, was more stringent than almost all other countries or regions. It comes back down, but not as far as the lower level of stringency for other countries, and then goes rocketing right back up again, of course, around the time of the second wave.
Yeah.
And we can see, if you scroll back out, a similar pattern of cancelling public events, restrictions on gatherings, closing public transport, stay at home, but particularly restrictions on internal movement, a very high level of stringency, effectively during the first wave, and then, relatively speaking, a very considerable drop in the level of severity, the summer of 2020, and then moving right back up again at the time of the second wave.
Correct.
What that shows, does it not, is that there was a degree of roller coaster element in the United Kingdom's response. By comparison, I emphasise, to other countries, we went right up the scale and reacted, some would say overreacted at the first wave, then underreacted between waves, and then rocketed right back up again at the time of the second wave.
There's certainly in the United Kingdom's response, as in many other countries, I should add, a element of ramping up, ramping down, ramping up, ramping down, and so the metaphor of a roller coaster does come to mind. The important difference between this line of red line showing the United Kingdom as a whole and the other countries listed here is, of course, these are averages, the other ones, so there'll be within every one of those lines a number of countries, some a bit higher, some a bit lower. This is showing the central tendency of these different groups. And so as the legend has fallen off the screen, zoom in here, but you'll see that, for example, the yellow line is parliamentary democracies across the world, and indeed the UK is higher right through to the middle of 2021. After spring 21 becomes much lower on average across all these different measures.
You have already taken us to the earlier charts, which showed us much more carefully the delay at the beginning. These charts show overall the level of stringency over time. Are you able to reach a view as to whether, in general terms, the United Kingdom applied non-pharmaceutical measures only when it became apparent that they were unavoidable because they were delayed, and at the time at which they were then imposed, we know in the United Kingdom the NHS was believed to be likely to collapse. And then when they're lifted, there is then a long period of delay before consideration appears to be given to their reintroduction. And then when they are reintroduced, again, because of the passage of time and the lateness, there is a requirement for those restrictions to be ever more stringently reimposed.
Correct. So we see this roller coaster tendency where restrictions are put into place only after it becomes apparent there'll be a very severe threat to the health system. That's after a large amount of community spread has begun. Because it's so prevalent at that moment, the restrictions need to be more stringent and to be in place for a longer period of time than might have been the case otherwise. But precisely because sustaining high stringency for a long period comes with costs, there's huge pressure to roll them back sooner rather than later. And that leaves inevitably some residual virus circulating in the population, which lays the seeds for the next wave to emerge. And so this kind of tendency to act too late in the first instance and to take measures away too soon in the second instance does tend to lead to the peaks and troughs that these graphs show.
Do later charts and figures, which I won't in fact take you to, show that an analysis putting together some of the threads that you've identified of those countries which had significant or substantial testing, contact tracing and isolation systems against those countries which were not obliged to impose NPIs at such high levels of stringency because they had effectively delayed, show that the presence of significant testing, contact tracing and isolation measures allowed countries not to have to react by way of the imposition of such severe, stringent measures.
Indeed. So countries as diverse as Japan, South Korea, Vietnam, others were able to use testing and tracing measures to maintain a very low level of spread, and when a new outbreak would emerge, to quickly react to make sure those individuals were not involved in further spreading the virus. That prevented them from getting to the point of a wider population spread in many instances that would have required more restrictive, stringent measures to control. And so the effective use of these testing measures was a nice way of maintaining a low level of spread and therefore not beginning the rise of the roller coaster back up the ramp.
And did you also find a link between those countries which had that testing capacity and which were able to avoid relatively stringent NPIs and those countries which suffered the most in terms of excess number of deaths, economic performance, and general health impact?
Correct. So the countries that were riding the roller coaster were suffering from a trifecta of large health impacts, high, long periods of stringency, and negative economic consequences. And those that were able to maintain a low level of spread, perhaps through effective TTI measures, were able to have a better outcome on all three of those measures.
Overall, does the literature and the data from your tracker project show that there were some areas of conspicuous success for the United Kingdom? The speed and scope of its genetic sequencing, because that allowed it to be very well placed to assess the emergence of variants and the spread ultimately of the virus. A very considerable and impressive degree of ability to test and survey and keep tabs on the spread of the virus, particularly in the middle and later stages of the pandemic through surveys such as the ONS COVID-19 infection survey, and the speed and extent of the vaccine deployment.
Correct.
But the absence of a test, trace, and isolation process ultimately led to the data and the findings which you've reached in relation to the delay and then the repeated reintroduction of extremely stringent and damaging measures.
We do see consistently that countries that performed well and were able to avoid the rise and fall of cases, deaths, and restrictive measures were those that used the testing, tracing, isolation, and support measures effectively, alongside other measures.
Thank you very much.
Thank you very much indeed, Professor Hale. Extraordinary project.
Thank you.
I had no idea projects like that were going on. I think one of my previous witnesses asked for global comparisons, so extremely helpful. Thank you.
You're very welcome.
Right, shall we break now for lunch? Because I think this
Certainly.
afternoon's witness is here, but you probably would like to have a few.
By all means.
1:45, please.
All rise.
Thank you.
Milady, the next witness is Sir Mark Walport.
I do solemnly,
Sincerely
and truly
declare and affirm
that the evidence I shall give
shall be the truth, the whole truth, and nothing but the truth.
shall be the truth, the whole truth, and nothing but the truth.
Could you give the inquirer your full name, please?
Yes, I'm Sir Mark Jeremy Walport.
Sir Mark, you gave evidence in Module 1, so let me welcome you back.
Thank you.
And thank you for the provision of a further statement, and this time the Royal Society report, to which I'll turn in a moment, in relation to which you are the chair of the expert working group.
That's correct.
You are well known to this inquiry. By practice, you specialise in clinical medicine and research as a general physician and rheumatologist. You latterly became head of the Division of Medicine at Imperial College. You were director of the Wellcome Trust from 2003 to 13, and most pertinently, perhaps, from April 13 to September 2017, you were the Government Chief Scientific Advisor.
Correct.
Your successor was Sir Chris Whitty on an interim basis.
Correct.
He was followed by Sir Patrick Vallance, as is well known. The current incumbent is Dame Angela McLean, and she took up her post in this year, 2023. You were also the founding Chief Executive Officer of the United Kingdom Research Institute, if I have the acronym.
Research and innovation.
Thank you very much. I began to pause. I wasn't sure I'd got that one right. The UKRI is an amalgamation, is it not, of what were formerly known as research councils. It provides funding to researchers, businesses, universities, charities, NGOs and the like in relation to the broad field of science and medicine.
Broader than that, actually. So it was created by Act of Parliament, came into existence in 2018, and brought together the 7 research councils, which cover everything from the arts and humanities, to the biological, physical, medical sciences. It also brings together the UK's innovation agency, Innovate UK, and also, in the case, and for all those activities, is UK-wide. It also incorporates Research England, which provides infrastructure support for English universities.
And could you please, whilst you give evidence, it's my fault for not reminding you, try to go as slow as you possibly can.
Yeah, sorry.
The reason I ask you about the UKRI is that during this pandemic, although you were no longer the government's chief scientific advisor, did you nevertheless attend no less than 54 meetings of SAGE in your role as the CEO of the UKRI? Why was that?
I did, and it was because an important responsibility for UKRI was funding the research and indeed the innovation appropriate to a national emergency. And in the context of that, and actually one of the reasons for the creation of UK Research and Innovation is that that research included everything from biological sciences around the virus itself, right through to the social sciences funded by the Economic and Social Research Council.
And so by virtue of your attendance on SAGE, you were able to be there as the CEO of UKRI in order to promote the early and rapid funding
Yes.
of the various the various pieces of work or research or accumulation of data that SAGE required to be done.
Absolutely. It was part of, if you like, a two-way transmission mechanism between the mechanism that provided scientific advice through Sir Patrick Vallance and Sir Chris Whitty, so that we could be sure that the research was relevant wherever possible.
As part of your many roles, are you also an elected fellow of the Royal Society, I think, a position that you have held since 2011, as well as being its vice president and, wonderfully, its foreign secretary.
Indeed.
The Royal Society is, I think, the oldest scientific academy in existence, releasing continuous existence, having been founded in 1660. But it essentially recognises, promotes and supports excellence in science. And is it by virtue of that function that you came to chair the working group that produced the report that you have exhibited for us?
I was actually asked to chair it before I became the Foreign Secretary, by virtue of my sort of broad expertise in the area. The Foreign Secretary bit came later, and reflects the fact that science is global. And so the Royal Society, from its inception, was very international in its outlook to research.
The report that the Royal Society has produced, and it forms the heart of your evidence in this module, was produced and published, was it not, in order to set out, in general terms, what has been learned about the effectiveness of the application of what we now well understand to be non-pharmaceutical interventions. Is that correct?
That's correct.
And did the working group, which comprised, I think, 6 groups of researchers, the world, in order to be able to determine the effectiveness of that application?
Yes, that's correct.
NPIs are usefully summarised at page 20 of your report. They're very familiar, of course, to this inquiry. They're defined in the report as any measure that is implemented during an infectious disease outbreak to attempt to reduce transmission that is not a vaccine or drug. They can be behavioural, social, physical, or regulatory in nature, and they can, of course, be encouraged to be adopted or applied through a variety of approaches, from advice and guidance to the force of law. And they comprise masks and face coverings, social distancing and lockdowns, and over the page, test, trace and isolate, travel restrictions and controls, environmental controls, and communications, which, although not a measure, form an essential part of the debate about the efficacy of non-pharmaceutical interventions.
That's correct, and of course they all have in common that they're intended to reduce the transmission of an infectious disease, in this case a virus, by acting to reduce the exposure of people to the hazard, which is, in this case, SARS-CoV-2 virus.
At the heart of any examination of NPIs and of their efficacy, must there be an acknowledgement of the fact that every virus is different in terms of its forms and degrees of transmissibility, and that the first line of defense, if you like, in relation to dealing with a viral pandemic, particularly a respiratory one, was the application, the consideration of NPIs, because there were, of course, in those early days, no antiviral treatment and no vaccine.
That is absolutely correct. There were no specific medical interventions at that stage. But it's important to recognise that not only do different viruses vary, but the coronavirus itself varied over time. And the main driver for the evolution of a virus, or indeed a bacteria, is to reproduce more effectively. And so, in general, infectious diseases tend to become more transmissible. And so the barrier function of, for example, a mask becomes harder and harder as the transmissibility goes up.
In truth, all governments faced a terrible quandary, did they not,
Yeah.
in the early days of the pandemic, because it was simply not possible to know with any degree of exactitude the nature of the likely spread of the virus. And under that heading, one might include a lack of understanding of COVID, the coronavirus's reproduction number, whether it was asymptomatic or pre-symptomatic, what its incubation period was, what its latent period was, what its generational period was, how quickly it would double in size, and so on. All that was unknown.
Absolutely.
And so, to a very large extent, the application of non-pharmaceutical interventions took place against a significant background of ignorance.
Yes, that is absolutely right. And whilst the principles of how non-pharmaceutical interventions work, as I've already said, because every infectious disease is slightly different, then policymakers were faced with an extremely difficult challenge, which is new infection, as you say, much not known about it, its clinical features poorly understood. But nevertheless, there were signs that this was a dangerous virus, and so important to take precautionary measures and apply non-pharmaceutical interventions.
And once it became apparent that this was a virus capable of causing death in large numbers, as well as severe injury, all governments faced a terrible balance or dichotomy, which was the absence of the imposition of non-pharmaceutical interventions would likely lead to unconscionable numbers of deaths, but the imposition of non-pharmaceutical interventions against that background of ignorance through no fault of government would likely lead to terrible cost and damage.
That is absolutely correct. And so a very strong incentive for policymakers to slow the spread of infection. And of course, the other thing at the beginning of this pandemic was that it was not known whether it would be possible to make a vaccine or what medical countermeasures might become available. But there's not only the direct consequences of the virus in terms of causing illness, but also the indirect consequences in terms of health systems becoming overwhelmed, the danger of the breakdown of other aspects of national infrastructure. And so every incentive to take quite a strong precautionary principle and do the very best possible to slow or, if possible, to stop the spread of infection. And some countries did take a zero COVID approach from very early on. In other words, they tried to eliminate the spread.
I'm pleased to say that we shan't be engaging today,
No.
Sir Mark, in the conceptual debate of suppression versus mitigation.
Correct.
But that debate is reflective, isn't it, of one of the many extremely difficult decisions that all governments have to make. At the time of the commencement of the pandemic, was there much by way or any objective analytical information or research available to governments as to the likely effects or impacts of this broad range of non-pharmaceutical interventions?
Well, once it became clear, which it did fairly rapidly, that it was transmitted by a respiratory route, then there was a lot of evidence that if you could keep infected people away from uninfected people, that would reduce the transmission. So every reason to think that non-pharmaceutical interventions would be effective, but how effective was unknown.
Was there a large or any body of randomized controlled trial work or analysis from empirical data as to how in practice any of these NPIs would work?
No, minimal information, because so much depends on the transmissibility of the virus and the details of the route of the transmission. So there was very, very little prior evidence.
And do we therefore take it from that because governments were forced at great speed to apply non-pharmaceutical interventions at the commencement of the pandemic, there was no opportunity for them to be able to put into place at the same time any sort of system for empirical conclusions to be drawn about how effective the steps were that they were putting into place?
I think it would have been extremely difficult, certainly in the absence of prior preparation of protocols. And it's also worth saying that if you want to explore the specific effectiveness of one of these non-pharmaceutical interventions, then the perfect experiment is to have a population, half of whom do use, half of whom don't, or use a different one. But it was policymakers recognized that you need to use non-pharmaceutical interventions in combination. And so there was a priority to introduce measures in combination.
And bluntly, the government had to get on with the job in hand and
Absolutely.
do whatever they could to combat the virus with
Correct.
maximum speed.
Correct.
The study which the Royal Society has therefore carried out is an observational study, is it not?
It's a systematic review of the evidence. In other words, it's to look at all types of evidence. And in some cases, there were trials which were deductive. In other words, you could compare a group using masks and a group not using masks. But by and large, because non-pharmaceutical interventions were introduced in combination, it was extremely difficult to dissect the relative effects of one non-pharmaceutical intervention against another. So to give you a concrete example, when strong social distancing measures are applied, then is the effect due to wearing a mask or to the social distancing? And so the groups reviewed an enormous amount of evidence and came down to a relatively small number of studies in the hundreds where it was possible to achieve some deductive information about the effectiveness or otherwise of the non-pharmaceutical intervention. But for those systematic reviewers who are used to working with placebo-controlled clinical trials, they would view the quality of the evidence as being far weaker. But on the other hand, observational research is important, and indeed, going back through the history of the Royal Society, is the way that we have learned about all sorts of things. You can't always do an experiment. You have to rely on observational data. So we did the work in two parts, really, which was to try and work out as much as we could about each of the individual non-pharmaceutical interventions. But we also did a number of country case studies, because that gives you a different observational approach to what happens when things are done in combination. You can learn quite a lot from those.
And were those three case studies, in fact, studies drawn from Hong Kong, New Zealand and South Korea?
That's correct.
Finally, by way of introduction, the value of the Royal Society's report to this inquiry is, if I may say so, self-evident. But for what general purposes did the Royal Society engage this valuable piece of work? Is it, if I may ask, in order to promote the general learning and understanding of this topic, or did you have an eye towards its use and its importance for the purposes of future crises which might befall us?
I think the answer is both, actually. Research advances through individual discoveries, but importantly, it advances through the aggregation of knowledge derived from a variety of studies. During the pandemic, the Royal Society did convene two committees to provide evidence reviews. And so it was a logical extension of that work that at a time when it was really important to understand the best evidence that we have on the effectiveness of non-pharmaceutical interventions, it was a timely report to produce.
It's implicit in what you've said already, Sir Mark, that the review comprised a minute examination of studies and reports and research material from across the world.
Yes.
One of the core participants has asked the inquiry to ask of you the extent to which the research covered material produced in or relating to Wales. And I suppose one could draw from that question a wider question, which is, can you say anything about the degree or the proportion of that research material which related to the United Kingdom as opposed to the rest of the world?
I don't think I can answer that question specifically. We deliberately looked worldwide, and the criteria for inclusion was that it was published in English, and so I can't answer the question specifically with respect to Wales. But I can say, as an example of a study which is actually slightly outside the remit of this, we learnt an enormous amount about the efficacy of the vaccines from studies that were done at a population level in Scotland. So we were more interested in the evidence and its quality than its geographical origins.
Thank you very much. Could we now then turn, please, to the general findings?
Yeah.
The conclusions reached by the research done by the Royal Society in relation to each of the NPIs, and we'll pick up the thread, if we may, at page 28 of the Royal Society report under the heading of masks and face coverings. In general terms, prior to the Royal Society's report, there was very little material by way of previous systematic reviews into the effectiveness of the wearing of masks. And by masks, I mean cloth and medical and respiratory and the whole range of masks. Is that correct?
That's correct. Yeah.
The research looked at available evidence in relation to the efficacy of all masks, as I've suggested, respirators, surgical masks, and face coverings such as cloth masks. Is that correct?
Yes.
And there were a number of 35 observational studies, in fact, which were looked at. And in relation to the effectiveness of masks in reducing SARS-CoV-2 transmission, if we go over the page, did the majority of the studies themselves conclude that masks and mask mandates, by which I presume you mean mandatory orders to wear a mask, reduced infection compared to those studies that found there had been no effect?
Yes. So there were 35 studies in community settings. 3 of them were, in fact, randomized controlled trials. And there were 32 observational studies. And then there were a further 40 studies in healthcare settings, one of which was a randomized controlled trial, and 39 observations. And the majority of those studies, the large majority, showed that the masks were effective. Importantly, there was a gradient. In other words, respirator masks were more effective than surgical masks, and mask wearing in the context of a mandate, in other words, an instruction with more or less legal force behind it to wear masks, were also more effective. So, if you like, the plausibility of the results was emphasized by that gradient of effect. In other words, you might expect that a very, the sort of mask that you'd wear in if you were exposed to a dangerous toxin is much more likely to be effective than a loosely fitting mask. I should qualify by saying that there was information about mask wearing in other infections, and in fact there were evidence syntheses, and we've learned about flu as well. So it's not that there was no evidence, but there was no evidence in relation to masks in coronavirus.
The issue of mask wearing is a particularly vexed one in the context of the general population. To what extent did the research indicate a level of efficacy for cloth masks of the type that the government might order or mandate a population to wear, so non-medical?
I don't think there were any of the systematic reviews that could distinguish between, say, cloth masks and surgical masks. So I don't think we have the information to answer that.
Was there also, do I remember, conflicting advice about mask wearing and its effectiveness and whether it engendered complacency?
There are lots of interpretations of the evidence, and this is one of the challenges with observational data. It could be that those who avidly wore masks of any sort were more likely to socially distance themselves. So there are other interpretations, but nevertheless, and particularly I think in the healthcare setting, where people are more likely to wear the masks correctly as well, because anyone who saw mask wearing, a lot of masks were worn underneath the nose where they would do no effect or weren't fitting properly. So it's another case where the fact that actually they were shown to be effective in healthcare settings suggests that there was, if you like, a causal relationship between the mask wearing and the protection.
The next broad group of NPIs that the research addresses is the social distancing and lockdowns on page 31. Under that heading, does the report include recommendations for people to stay separated from other individuals, as well as legal mandates to stay at home?
There were 34 studies on physical distancing, as opposed to 151 studies that were looked at stay-at-home orders. So the group that did the social distancing and lockdown work divided into, I think, 9 different groups of social distancing measures, which included restrictions on mass gatherings. I won't read them all out, but they're listed in the report.
Workplace closures, school closures,
correct.
Care home measures, mass gathering, and physical distancing. And in general terms, and I suggested similarly to Professor Hale before you, perhaps not surprisingly, the research showed that these social distancing measures were associated with considerable, that is to say, significant reductions in community-level transmission of SARS-CoV-2.
That's correct.
Was there a link found between the degree of stringency in the application of these various measures and the degree of reduction in transmission?
Yes, broadly there was. So stay-at-home orders, the more stringent the measure, the more effective. The restrictions on mass gatherings were important. But each of them were effective. And, of course, quite often these were applied in combinations as well. And I think it's important, we will come back to it, I think, but NPIs work in combinations. That's the critical thing, that none of them, physical separation on its own, if one had been able to physically separate people for a prolonged period of time, would have a very profound effect, but would also be possibly unhealthy in other ways.
But a stay-at-home order will, of course, encompass necessarily within the effect of such an order a form of distancing, a social distancing, as well as, depending on the width of the stay-at-home order, an impact on schools, workplace, and...
Absolutely correct. But, of course, stay-at-home orders are, have to be modified in order to keep a nation working, and so key workers would still have to go to work. But correct.
And one of the more important points in this chapter concerns the recognition of the effectiveness of social distancing and the importance of social distancing in care homes.
Yes.
Because some of the research showed quite plainly that strict cohorting of staff alongside residents and restrictions on visitors was associated with significantly reduced transmission. Again, unsurprisingly.
Yes, I think that's exactly right. I think that none of this is surprising when you think about the first principles of stopping an infected person infecting an uninfected person. So, but that is absolutely right. In care homes, if you could restrict the movement of care workers, for example, between different care homes or between different populations, that reduces the chance of anyone infected, in this case an infected care worker, infecting large numbers of people. So that's important. And equally, if you have got people in a care home who are infected, then keeping the staff that look after them separate from uninfected people is important.
Test, trace, and isolate.
Yeah.
Quite plainly, again, there were a number of papers and research articles to which the report had regard. And some of that material, in fact, comprised detailed data from the United Kingdom, did it not?
Yes, particularly the app that was used on the Isle of Wight.
But was that when the government introduced, by way of experiment, a non-Apple, non-Google app, and they applied it across the Isle of Wight to see what the response would be and whether or not it was effective in ensuring compliance with
That is correct.
social distancing?
The evidence overall is strong that if test, trace and isolate is applied early and effectively, then it's actually quite a powerful measure, and we may come back to it when it comes to the discussion of Korea. But almost all of these interventions, the other thing we haven't specifically talked about is the sort of the force of transmission. In other words, when there are a very large number of cases in a community, so the exposure goes up. And in the case of test, trace and isolate, when you've got very many cases, then it's very difficult to apply it at a national level. And so with all of this, early application is important.
And that's a point, if I may suggest, of enormous importance in the case of the United Kingdom, because the position was, wasn't it, that, and it's well established, that there was no significant or comprehensive test, trace, isolate system in the United Kingdom in the early days.
Yes.
And what the evidence from South Korea, along with New Zealand, Australia, and a number of other countries, shows that if there is in place such a system, it becomes possible for the government to be able to control the spread of the virus before it runs away.
Yes, I think that is correct. It is, of course, difficult to extrapolate between different countries because, of course, the application of all of these non-pharmaceutical interventions depends on all sorts of social and cultural issues as well.
Of course.
Korea was very well prepared because it had had the outbreak of MERS in 2015. And I think it's fair to say that not only the government was more prepared, but the community was aware of what happens when you have a dangerous virus in your country. And so they were able to adopt. So testing on its own with sort of voluntary isolation doesn't work nearly as well as if you've got very systematic testing coupled with the tracing and the isolation. Those are the key other elements.
And it therefore is the key feature to a system, a comprehensive, scaled-up system of test, trace, contact and isolate, that it is necessary but not sufficient, because it may only work either at the beginning of a pandemic or during the course of a pandemic below certain levels of incidence. That is to say, the spread of the virus or the level of incidence of the virus has to be below a point at which this system of test and trace can work in practice.
Yes.
If the level of incidence is too high, no system of test and trace, however sophisticated, could get on top of the problem.
When the level is very high, then essentially you end up testing, tracing, and isolating the whole country, which is where you get to lockdown measures. So it is exactly as geographically limited and low levels, that you can remain able to test at sufficient scale and bring it under control without locking down everyone.
We may never know what the effect would have been had the United Kingdom had a comprehensive scaled-up test and trace isolate system at the beginning. But is there anything that can be said about the levels of incidence, the level, the spread of the virus in the early days in the United Kingdom?
Well, the one thing we do know is that in February of 2020, there were about independent importation of cases, which was across the whole nation, from people who'd been away during the half-term school holidays in Italy and Switzerland, who'd been on skiing holidays, and because they were a young and fairly fit population, they managed, the sort of severe morbidity wasn't really seen in that population. So the UK was hit in a very widespread way very early. We didn't have tests nearly as early at scale as Korea did. So a lot of this comes back to the evidence I gave actually in Module 1, which is the real challenge for nations is to be prepared.
Of course. And were genomic studies, in fact, subsequently carried out, in particular a main study in the summer of 2020, which was able to trace back the genetic origin of a large number of infections
Yes,
in the United Kingdom to viral infections in France, Spain, and Italy.
Yes, that is correct. And as a result of that, we knew that these were independent introductions.
There was what is known as a widespread, a widespreading of individual separate infections across the United Kingdom.
Yes. I think it may go slightly beyond this report, but there were important sort of chance events in different countries that altered their experience of the disease. And obviously those countries that are extremely well connected global transport hubs had more exposure early on.
You make the point on page 35, in addition, that even where COVID-19 cases are higher, so even where there is a higher incidence, test, trace, and isolation may still have an important role to play because, of course, it can still suppress, perhaps only around the outer margins, but it can still suppress the virus even if it's not able to completely control its spread.
Well, that comes back to the need for the combination of measures. And so, but I mean, you need a very high intensity of testing if you're going to be able to be effective when there's. The question is really whether the outbreak is geographically localized or whether it's spread.
Well, that leads us on very neatly to the next broad area of NPIs, travel restrictions and controls across international borders. Does that cover, in fact, quite a wide range of measures from screening,
Yes.
checking people's temperatures when they come across a border or looking for signs of fever, all the way across the spectrum of measure to shutting a border or only allowing people in with full isolation and quarantine?
It does, and it includes a quarantine as part of it as well. So shutting a border completely is extremely difficult for almost any country in the world because most countries depend on the importation of goods and services. And so how do you deal with the necessity for people to come in? And of course, quarantine is then a very powerful tool for that.
Starting at one end,
Yep.
that screening measures were particularly effective in controlling the spread of the virus?
Screening measures were very weakly helpful because of the incidence of asymptomatic infection.
Could you just elaborate, please, on that?
Yes. So if you have someone that you're screening on the basis of the fact that they have a temperature or they're coughing at the border, that will only pick up people who have symptomatic infection. On the other hand, it may be that there are people who are either infected but have no symptoms, or in fact are in the earliest days of an infection, and even a PCR test might not become positive for 2 or 3 days after they've crossed the border. So simply health screening on its own, even with a one-off PCR test at the border, will leak. People will leak through who have the infection.
And standing back, of course, every government which is considering any sort of border measure has to grapple with the conundrum of what the impact would be of the imposition of border measures in terms of trade, travel, and that presents an even greater problem for those countries like the United Kingdom, which are more interconnected and engage in greater levels of trade than some others.
Yes, that is correct. And there's also the question of the prevalence of the virus in the country that people are coming to compared with the country they're coming from. So if you're coming from a country which has the same variant at the same level, border controls won't have much efficacy. On the other hand, if they're coming from a country with a much higher rate of the virus, then they are potentially very important. And also, when you've got new variants emerging, you may be able to slow them down.
And if a country already has COVID established in it, stopping individual members of the public travelling into that country will be like, well, allowing them in might be, I think it's been described as throwing a lit match onto a
yes,
raging fire.
But with the exception that if there are new variants emerging, then that may still be relevant. But I think the real point about the travel measures is that, again, you have to implement a comprehensive package for them to be effective. And I think New Zealand is quite an interesting example we'll come to, where they have the advantage that they're geographically isolated. I mean, basically you get there by plane or occasionally by boat, ship. But they found even with the most stringent application of border controls, there would still be influx into the country. So, for example, at the border, it may be that a border official or someone supervising a quarantine facility could become infected and carry the infection into the country. So, border controls are only effective in the context of other stringent measures as well.
And so that we may be clear, in those small number of countries where rigorous border closures enabled those countries to keep a tight grip on the virus, and by and large thereafter to avoid long, stringent national lockdowns, for example, those border closures were coupled with other NPIs, but in particular TTI, test and trace.
Absolutely. It was test, trace and isolate coupled with border controls. And of course, it was found that long periods of quarantine were more effective than short, that compulsory quarantine was more effective than voluntary quarantine. And later on in the pandemic, it was found that you could probably reduce quarantine time, but effectively to keep your border as a barrier was an essential feature as well.
The next broad area is that of environmental controls on page 39. In the general scheme of things, if the rubric or the aim is to control the spread of a virus, how important are environmental measures such as air cleaning devices, ventilation, surface disinfection, screens, and so on?
I'd say that disappointingly, this was the area where there is the weakest experimental evidence. There are a small number of observational studies that appear to show the effectiveness of environmental measures, and that's everything from reducing the number of people in an environment to increasing ventilation. Again, everything that is known about the transmission of infection says that one way of reducing the exposure to exhaled virus is to increase the ventilation, so having open windows, increasing airflow. But there is remarkably little rigorous evidence that can be adduced. And I think it's one of those cases where absence of evidence should not be taken to be evidence of absence. In other words, because we can't demonstrate it doesn't mean that there wasn't an effect.
So we must leave it on the basis that there may well have been some beneficial outcome, but it's impossible to quantify it.
I think that's right. And of course, one of the purposes of the report was to provide recommendations for how we might fill evidence gaps in the future. And there is a clear opportunity to gather evidence when it comes to environmental controls.
Then the impact of communication, was that, you've already described how that's not strictly a measure or an NPI, but it's an extremely important facet of non-pharmaceutical interventions, because unless the community adopts and complies them, then their efficacy would be significantly underwhelmed.
That's correct.
Was this a topic in which you looked specifically at the United Kingdom position?
We did, because the cultural context of communication is so specific. So we restricted ourselves in this case to the United Kingdom. Of course, communication interfaces with all sorts of other cultural aspects of the society. So, for example, social cohesion, altruism, all sorts of features of society. And so we did restrict ourselves. The evidence is that people did largely comply, so the communication was working overall, although there were certain features about the communication, such as the trusted communicator, persuasion rather than coercion, a number of features like that that were more likely to engender trust, because trust in the communications is extremely important, and the corollary of trust is trustworthiness. And so communicators who were seen to be trustworthy were by and large well trusted.
2 points arising therefrom, please, Sir Mark. Firstly, was trust found to be the most common factor in terms of impacting upon the effectiveness of communication?
I think it's a major factor, but clarity, consistency, a balance between, whilst being authoritative in as it were, the reliability of the information, not being too controlling. So, but I mean, all of that in a way integrates into
Trust.
I
in fact, was reading out the words of the report itself, Sir Mark. Trust was the most common factor impacting communication effectiveness.
Yes.
And secondly, could you just elaborate, please, on the importance of knowledgeable and trusted local groups and leaders as communicators? So in the particular context of members of the ethnic minorities, how important is the existence of knowledgeable and trusted local leaders in the communication of NPIs and the promotion of trust?
I think one can extrapolate from advice, say, on vaccines to NPIs, because I think there is a sort of common denominator. And certainly when it comes to improving uptake of vaccines, then there's pretty good evidence that people trust people who they feel are like them in similar cultures more. And so it is important to have that communication distributed and reflecting the diverse nature of a community.
And 3 sub-issues, if I may. Firstly, how important in the development of trust and the promulgation of effective communication is the need of consistent messaging and the absence of conflicting or changing messages?
I think that there is little doubt that consistent messaging is extremely important. And that then takes us to how uncertainty is communicated as well. And uncertainty is sometimes communicated as X has one opinion and Y has a completely opposite one, and that then sends very confusing messages.
And because you were looking particularly at research emanating from the United Kingdom, was one of the findings of the report that government guidance in the United Kingdom, which had, as we know, changed multiple times, and of course changed across devolved administrations as opposed to the United Kingdom, led to the potential for non-compliance simply because people became either confused or desensitized.
Yes, I'm not sure that the evidence is that rigorous on that, but I think it's a reasonable interpretation of what happened.
And thirdly, to what extent is an absence of scientific certainty damaging to the efficiency or efficacy of communication? So, putting it bluntly, to what extent does a population need to know the scientific basis for what is being told in order to make it comply?
Well, but that's an interesting question, but it goes back to the start of the pandemic, and even at the end, there were huge numbers of things we didn't know. And what is known. So whilst everyone, as soon as possible, we started with hardly any specific answers. We had generic answers, and so that communication of uncertainty and the communication of science in general. It's the whole nature of science to be sceptical, actually, to want further evidence. And I think the evidence is actually that the public, and there isn't one public, but public audiences, did accept and understand the fact that there are things which were not known.
You say the whole nature of science is to be sceptical. Was it you who described scientists as licensed dissidents?
No, it wasn't me, but it could have. It could have been, but it wasn't. No.
And therefore, in conclusion on this part of the report, do you call, in fact, on page 44, for governments in future to convey information clearly with consistent messages? They're on the top right-hand corner.
Yes.
To convey information by trusted sources, such as health authorities, but in fact, there's a reference back to knowledgeable and trusted local group leaders.
Yep.
And thirdly, there must be a proper balance struck between authoritarianism and optional.
Yes, yes. Those were the summary of the evidence review there. That's correct.
You then turn, or rather the report then turns to a cross-national comparison of NPI effectiveness. You're aware, of course, of the report from Professor Tom Hale.
Yes.
You may indeed even have seen his evidence earlier today. In broad terms, are the conclusions from the Royal Society report very similar, although they come at it from a different angle, to the conclusions reached by Professor Hale, to the effect that the more stringent an NPI, the more effective it is likely to be, and also that the availability of comprehensive scaled-up test and trace and isolation measures are likely to be of the very greatest importance in being able to keep control or to regain control of a virus.
Yes, I read Professor Hale's report. I was sort of locked away in a room out there whilst he was giving his evidence, so I didn't hear it. But I enjoyed his paper, and actually I was pleased that it was very complimentary to the paper produced from the Royal Society. So he came from the observational angle of looking at policy implementation in different countries across the world and correlating it with COVID cases.
But when you say complimentary, I should just make plain, you mean it went very well alongside,
yes,
it complemented it rather than being very nice about it.
Yes, correct. Yes, with an E, exactly. I did my research on a system of proteins called complement with an E, and people used to misspell it all the time. So, but yes, and of course the angle from the Royal Society report was to do systematic review of the evidence directly. But when it came to our national case studies, they fit more with the approach that was taken by Professor Hale.
Could we then turn briefly to those three case studies, that's to say Hong Kong, New Zealand and South Korea? Mm-hmm. I don't want you to give an account of how the Hong Kong authorities proceeded throughout the whole course of the pandemic in relation to their imposition of NPIs. But focusing on the broad thrust, and painting it in a very general term, in a very general way. The Hong Kong authorities applied very early on, stringent NPIs because of boundary closures in early February, a full quarantine policy, either at home or in a hotel, from March for travellers arriving from Europe and North America, and then from July, quarantine for all arriving persons. Is that a fair summary?
Yep.
And therefore, they were able, or rather, the virus never escaped their control.
It escaped. They were able to keep it under control. So yes, it didn't escape in the sense it was there,
Indeed.
but at very low level. Yeah.
And where it popped up, the system for test and trace, and in particular isolation, was able to deal with outbreaks of the virus over time.
Yes, that's correct.
But where Hong Kong suffered terribly was that when these stringent NPIs were lifted, it became apparent that the levels of vaccination in the population were not as they should have been. There were very large numbers of elderly members of the Hong Kong population who were not vaccinated. And so when, in particular, Omicron broke through,
Yes,
they were vulnerable and they died in very large numbers.
that is correct.
So Hong Kong is a very good example of the beneficial impact of go early, go hard in terms of the early imposition of stringent NPIs
That is correct.
with vaccination.
That is correct. And of course, that was the remarkable thing about this pandemic, which is that within a year of the pandemic started, there were vaccines that stopped people dying. Yes, but that's a correct analysis.
New Zealand recorded its first case of COVID-19 on the 28th of February, not entirely different to the United Kingdom. But 2 weeks later, on the 14th of March, it was announced that anyone entering the country must self-isolate for 14 days. Border until the point at the 9th of April when only New Zealand citizens and residents were permitted to enter the country at all, and even they had to undergo a 14-day quarantine.
Yes, a compulsory quarantine, which was observed, as it were. Yeah.
And therefore, although there was a 1 month strict lockdown and a whole series of local lockdowns, so attempts to suppress local outbreaks, and a fairly low level of domestic NPIs imposed, New Zealand remained mostly transmission-free until late 2021.
Yes, that's correct. I think New Zealand provides a very clear illustration of what is needed to make border controls work, because we do have very good There were then episodes that suggested there was domestic transmission occurring, so you wouldn't have been able to do contact tracing right back to the border. And under those circumstances, they imposed quite strong localized lockdowns. And so I think it's an extremely good example of how, if you're going to make border closures work, you have to do a whole lot of other things as well.
And you must make clear, mustn't you, that, again, to repeat perhaps the obvious, we will never know whether the United Kingdom, had it had a developed system for test, trace and isolate, and had it had quarantine facilities, and had it had the geographical, the population density and the socioeconomic conditions which apply in New Zealand, would have been able to keep the virus under similar control.
That is absolutely correct. So we have a much larger population, a much higher population density and interconnectedness, And although we are an island with only a short sea barrier to other parts, lots of shipping, and so it is very, very difficult to extrapolate from one country to another.
But what is clear is that the New Zealand imposition of border controls was, by the general scheme of things, applied very early.
Yes.
And secondly, whether or not it was to do with the early application of those border NPIs, they didn't appear to have suffered in the same way that the United Kingdom did from multiple, indeed nationwide, seeding of infection in those weeks in February.
Well, that's true, but in fact, I mean, the full rigorous quarantining in New Zealand didn't happen until the 9th of April. They had a more voluntary policy until then. Of course, in the UK, by the 14th of March, we'd already had a very substantial introduction of cases. And they did have, actually, New Zealand, quite a long national lockdown as well. So, but I mean, the general principle is correct, that having controlled the first major outbreak, then after that they were able to maintain it by rigorous border controls coupled with other measures.
And by the 14th of March, anybody entering the country had to self-isolate for 14 days. So had there been multiple seedings around that time in New Zealand, and we will never know whether there were or not, there is at least the prospect that that mandatory self-isolation would have had a beneficial impact.
Yes, what I can't tell you is how effective that self-isolation was.
Indeed. And then finally, South Korea. South Korea's population is 51.4 million, so I think 15 to 20 million perhaps shy of the United Kingdom, so not entirely unequal in size. It is very well known, experienced an outbreak of MERS, which had, of course, although more localized, a high consequence infectious disease, had a much higher rate of fatality, and it had also therefore put into place and developed much more active measures for the control of disease.
Yes.
The SARS-CoV-2, coronavirus 2 infection was first identified in South Korea on the 20th of January 2020. On the 23rd of February, public health authorities raised the infectious disease alert to the highest level, and then combined NPIs were applied over time. Did South Korea have a very sophisticated, a sophisticated and developed system for community-based screening, for test and trace, and in terms of contact and isolation, very sophisticated systems for electronic contact tracing. So people could be traced through credit card or debit card use, through CCTV, through their location because of mobile phone use, and so on and so forth. What was the outcome of the application in general terms of that level of stringent NPI?
Well, they managed to avoid the need to have a lockdown. It illustrates prepared. So they had learnt a lot, as I said earlier, from the MERS outbreak. They'd strengthened their epidemic intelligence service, and so they were prepared to develop an extensive test, trace, and isolate very early. South Korean infection, the UK case was in January as well. They avoided a national lockdown. Organisations on a couple of occasions.
But notwithstanding those super spreader events, their system for NPIs, or their system of measures, enabled them to circumnavigate.
That's correct.
They were able, were they not, to gain approval for a diagnostic test at a relatively early stage,
Yes.
on the 4th of February, and does other evidence show that by late March that they were testing individual members of the population at a prodigious level?
Yes,
way
they
ahead of
scaled
the United
up
Kingdom.
way ahead of, I would need to check, but I suspect almost every other country in the world. They were very, very fast.
The report draws the threads together if I may call them that, from page 63 onwards, Sir Mark. I needn't, I think, trouble you with the summaries that are set out there in relation to the need for going early, go hard, and for the link between stringency and reduction in transmission, because you make these points. Firstly, on the basis of strict early application of NPIs, it is obvious that it was that combination of NPIs that was crucial in terms of efficacy. Secondly, that the value of a proper test, trace, and isolate system is enormous. It is perhaps the core NPI if the aim or the goal is to stop a runaway infection or to try to regain control. Third, as you've already indicated, it is not possible, however, to reach counterfactual conclusions. What might have happened here if, and so on. But fourth, the key lesson to researchers is to be prepared, because it is only by understanding as fully as we may the impact of non-pharmaceutical interventions will we appreciate the vital importance of test and trace and of ensuring that a combination of NPIs next time is used at the earliest possible moment.
Yes, so I'd qualify what you've just said, I think, in two ways. Firstly, the effectiveness of non-pharmaceutical interventions does depend on the transmissibility of the virus. And so no country in the world was essentially able to control it once the Omicron variant came out. That was the point at which China, with its very rigorous restrictions of mobility, just couldn't achieve it anymore. And so there is always that. But that is another argument for acting early, because now that we know that there is the potential for developing a vaccine during the lifetime, then your best chance of doing that is as fast as possible before the virus has had a chance to evolve to be more transmissible, because that's what they will do.
And just pause there.
Yeah. Yes.
One other ancillary benefit of stopping the spread of the virus is to stop, of course, the likelihood of variants, but also to stop the prevalence of syndromes such as long COVID, which come, of course, by way of injury from the widespread.
Well, that is correct, and also to avoid the need for prolonged periods of restriction of people's liberty with all the consequences that brings. So being quick and being stringent is very important. My qualification of the second comment you made, which is about how we acquire the evidence in the future, that isn't just for scientists, that is for policymakers as well. In other words, what we need in any pandemic, and indeed for public health as a whole, is high quality data. And so ideally, protocols need to be developed for how one might deal with the observational data in a future pandemic, because researchers can't do it in the context of an environment that doesn't allow them to. And so I think working with policymakers to agree potential protocols, to agree the sort of information that's needed, is really important. And ideally, this should be international, because you can learn things by comparing country A with country B, with the caveats of all the sort of cultural issues we've been discussing. But I think the scientific community, if there had been protocols of the sort that ISARIC, for example, had had in terms of the clinical description that I talked about in my evidence in Module 1, the International Severe Acute Respiratory Infection Consortium, they had protocols that they developed 10 years ago. And so were able to activate their studies very, very quickly within days of the pandemic starting.
To drill down just for a moment on two aspects of that very helpful answer. Firstly, do you set out in the report the need for, therefore, systems of accumulation of data and research to be put into place? So you say there needs to be, during the inter-pandemic period,
Yes.
the interregnum before the next pandemic, the pre-positioning of national and international research consortia and networks, methodological protocols and mechanisms for the collection of data. And do you mean by that we need to know in much greater detail what the likely consequences are of viral infection in terms of transmissibility and the epidemiological impact, but also much more about the NPIs which may be deployed in future to be able to combat it?
Yes, and the analogy is with drugs and vaccines, where because there were protocols that could be applied during the pandemic, we learned very rigorously and deductively about the effectiveness of, for example, dexamethasone in saving lives in people in intensive care unit, in learning which monoclonal antibody therapies were, anti-inflammatory therapies were effective and which weren't. In the same way, if we had very good continuous evidence collection during the pandemic, we might learn more in real time about the effectiveness of different measures at different times. As I've described, however, in relation to environmental measures, there are some things one can learn from experimental studies between pandemics. So it's perfectly possible to understand the distribution of particles of viral size in closed spaces, what ventilation might do. Some of that work is already done. But at the start, we didn't really know the balance of the importance of washing hands and cleaning surfaces. We do know that actually enteric infections, so infections of the gut, decreased. And we also know about the effectiveness to some extent of the non-pharmaceutical interventions from the fact that influenza and respiratory syncytial virus infections dropped during the pandemic. But ultimately, each infection is unto itself. Yeah.
And lastly, in the context
Is this last?
Yes, this is the last.
It's just I've been asked to take a break. So.
This is the last question. In the context of your earlier answer about the terrible conundrum faced by governments in relation to whether or not to impose non-pharmaceutical interventions, do you call for a much closer examination of, the need for a new structure or framework or a policy by which the relative benefits and costs of alternative steps which could be taken by government are examined? So Lord O'Donnell, you might know, has described as a well-being cost-benefit analysis.
Well, I think one of the things we say in the report is that there were costs in other domains of life, economic, people's well-being, education, and those need to be analysed as well. And I wouldn't dare to tell policymakers what the answer should be, but policymakers will always make the best decision, one hopes, if they have all the evidence. And so you need evidence on all sides of the equation.
Thank you. Milady, that does conclude the evidence of Sir Mark.
So I wasn't trying to hurry.
No. I had referred to the possibility that it was the last and final error about 3 times.
I'm not sure you're being fair on yourself there, Mr. Keith. Can I just ask one question, and this positively is the last. Given the importance you place, or the study, your report places on having a scalable system of test, trace and isolate, have you got any estimation of what our position is like today here in the UK?
I think it is not as strong as we would like it to be. But that is just...
And I didn't give you notice.
I think there is much more to do. We talked in my last appearance about the work of Dr. Kershell, who is one of your advisors on the history of public health. And I think that the disinvestment in public health, not just in the UK, but in the rich countries of the world, needs to be tackled. But that is a personal opinion rather than a sort of... it goes beyond this report, that's for sure.
Thank you very much, Mark. I'm very grateful. I hope we're not imposing on you too much. I have a feeling we may impose on you again if we may.
Really?
But, I don't know. I haven't checked with the other modules, but I'm extremely grateful to you again for all your help.
Thank you, milady.
I very much regret to say that it was Sir Mark's first question this afternoon.
Will we impose on again?
Would you be wishing to see him again? Milady, that concludes...
Obviously, we do have a module specifically on health, you see, Sir Mark, right. So it's just possible.
And that concludes today's evidence.
Thank you all very much indeed. 10 o'clock tomorrow, please.
All right.